you are back. You are not traveling.
Yeah. Share start. Yeah. Madam, please go ahead. Sampath ma'am.
Yes. Yes. Good evening to all. 1 minute. Hello. Good evening to all. Today we are on the third day of our adolescent certificate course. We had the wonderful topics on day 1 and day 2. Today is the third day of our adolescent certificate course. As all of us know, 23% of the adolescents are in the world populations, and India is having more adolescent. That is the reason we are conducting this adolescent certificate course. And this is the 8th consecutive year we are doing. Today we have first speaker being the HPV vaccination and how to do the counseling about this HPV vaccination. And then regarding this, the Dr. Shaijas and Dr. Josephine will be doing. And the next we go with that media influencer by Dr. Rajapriya. These are all the first session. And the second session being the endometriosis, the dysmenorrhea, which is increased with the adolescent. Medical management and surgical management by Kalpana. And we have the mass, other than the endometriosis, what are all the other adnexal masses, how to approach by Dr. Chinmaya Rathe, and the fertility preservation in adolescent by Dr. Kunju Moidin. Finally, we have the case scenarios, depending on the mental health and social health. It is moderated by Lakshmi Srikande, and we have the wonderful panelist, Dr. Sunit, Dr. Selvapriya, Dr. Radhika Gauri, and the psychiatrist, Dr. Janani. Then Suman Sinha also. So we have the wonderful topics, and all of you should have attended the 3 days, and you should have attended the post test. And if you are 50% pass on all 3 days only, you will be given the ICOG certificate. Now, without wasting time, I hand over the mic to Dr. Radhika Gauri to conduct the sessions. Thank you. I should thank Dr. Sunita, Dr. Swarna, Dr. Parag, and Dr. Sarita for accepting to do this adolescent certificate course in Foxy ICU. Thank you. Radhika, you can take over.
Yes, ma'am. Good evening, all the faculty and delegates. I thank the ICOG for giving me this opportunity, and I thank Sampath ma'am for this opportunity. Now, I invite Dr. Sarita ma'am to give the welcome address.
Thank you very much, Dr. Radhika. And I welcome all and one to this last and final day of this ICOG certificate course on adolescent gynecology. We've had a lovely 2 days. It's been really very fantastic. And we've had an excellent response. And I'm sure that the third day is going to be just as good. I'd like to really congratulate and thank the conveners, Dr. Sampath Kumari, for taking the lead in this course, Dr. Durga Shankar Das, and Dr. Supriya Jaiswal. And the coordinators, Dr. Supriya Arwari, Dr. Poonam Lad, and Dr. Radhika Gauri, who's going to be the coordinator for today. A big thank you to all the faculty and the chairpersons for all their efforts and time in preparing the talks and being there. And to our technical team, Jignesh and his team. And of course, to Nilima and Poonam for collating all the questions for the post test. I'd like to also tell you that our next certificate course is on the roll, and it's going to be on urogynecology, and with Dr. Kavita Barnwal, Dr. J.B. Sharma, and Dr. Suman Sinha actively working towards this course. It's going to be next month, and it's going to be in the middle of the month to in the third week, because we have the Foxy Managing Committee meetings in the last week. We also have a certificate course on menopause before the year gets over. So a lot of exciting things. But before I end, I invite all of you, please, to apply for FICOG. The application is open. It's on the website, icogonline.org. And if you apply now, before the 30th of September, you can get your FICOG in January. If you're falling short of the credit points, well, you can still take it next year in Bangalore in the month of August. With that, I wish this course all the very best and I look forward to an exciting evening. Thank you.
Thank you, Sarita ma'am. That's a wonderful news. We have more courses coming up. Thank you so much. And I invite Dr. Sadhana Gupta ma'am, who is the Vice Chairperson elect, to bless us with few words.
Thank you. And my all regards to all senior people, Dr. Parag, Dr. Sarita, who are taking the lead in the ICOG courses. And this certification course is actually ICOG UPS. You get insight, you get into intricacies, you get updated, and you test your like what you have learned with the post test, and then you get the certification, and which is the like a first step and the few steps ahead in getting availing FICOG, and then what next? There can be so many things. So Dr. Sarita has already said, join as ICOG. It is a college which is for you for over the life, and participate in activities of ICOG. My all appreciation for conveners, Dr. Sampat Kumari, who have been the like a firing a light in the Foxy as adolescent chair committee, and she has put such a great imprint on this subject, and Dr. Durga and Dr. Supriya, and all hard efforts which convener coordinators Poonam, Supriya and Radhika, and thank you for all your hard effort and contribution for making these certification courses a real big issue and a real great success. So today is the third day. We had 2 days full of knowledge, full of new insights into the adolescent health. And to all who are, I congratulate everyone who have joined this certification course, because as an Indian doctor, we need to be very, very sensitive to adolescent, not only health issues, what drugs we prescribe, how to make them, counsel them, how to talk with them, because in India, we have a large variation in socio-economic issues, and the adolescents are the people, actually that generation which actually faces a very unequal opportunity, very like a very restrained and constrained environment to liberal issue. So one thing I will say, that be very sensitive whenever we prescribe any simple drug like COC to adolescent. We must be thinking what is it is short-term effect, what are long-term effect, what is the duration. And the second thing is that this is very important, that we give all these the positive things. So that we see it is adolescent, it is impressionable age. And when we counsel, don't take them so much negative, don't make them stressful with so many advices. So this is something, always be very, very careful that you are giving positive message, because that positivity goes around. And always take the specialized issue in their life. It is not the same. It is not the US or UK or the Western thing. Our adolescents are entirely different, and we must have our own knowledge, own insight, own research and everything. So thank you. It's always a pleasure to welcome, and that too on the third day, and hearty best wishes to all. And we look forward to a great program. Thank you very much.
Thank you, ma'am. That was a wonderful talk by ma'am, Dr. Sadhana ma'am, and we will take your advice. Now we'll go on to the first session, HPV vaccination. So the chairpersons, I invite Dr. Sheila ma'am. Unfortunately, she's unable to attend. So I invite Dr. Meena Samant ma'am. She's the senior consultant and HOD Department of Obs and Gynae, Kurji Holy Family Hospital, Patna. And she's the General Council Governing Member, ICOG 2023 to 25. She's the President of Patna Obs and Gynae Society between 2023 to 24.
Thank you.
So I think before the speakers start, a sincere appeal to all the speakers, please stick to your time. So for last 2 days, the speakers have overshot time, and then we've received grievances from the delegates. So a request to all the speakers, you are given 15 minutes, you just have to finish in 15 minutes. Thank you very much for being part of the ICOG activity.
Thank you, sir. Thank you, Parag, sir. We'll keep a watch on the time. Thank you, sir. So I invite Dr. Meena ma'am. and Dr. Hepzibah ma'am, who is a professor, former superintendent government RSRM hospital, and she's a consultant in CSI Kalyani Multi-Specialty Hospital and visiting professor, Mahada Medical College. She was a past president of Obs and Gynae Society of Southern India and past president of Chennai Menopause Society and joint treasurer of Indian Menopause Society, treasurer as well. And she's received 2 Best Society Award during CMS President tenure 22 and 23. And she has numerous papers, and she's a PhD guide for SRMC Savita and SRM Medical College. And she's trained in robotic surgery, and she's given orations at OXY. She's a very good speaker. Thank you, ma'am. So let's begin the session. So, ma'am.
Yeah, good evening. Thank you, ICOG, for giving me the opportunity to be here today in the capacity of a chairperson. And it's a proud privilege to introduce Dr. Shaijas. And we do remember his term as the past chairperson in the Midlife Management Committee of OXY 21 to 24. And he's been a very active member of his society. And during his office bearership, be it as secretary or president, he has bagged so many awards for his society. It's a great achievement. And more than all, he's a great performer. We've heard him in his talks. We've heard him singing and also on the dance floor. Over to you, Dr. Shaijas. It's always a pleasure to listen to him. And he's going to talk on, yes, HPV vaccine, which is also very important.
Thank you. Thank you so much, madam, for those very kind words. Can I share the screen?
Yes, sir.
Yeah. I hope my slides are visible and I'm audible.
Yes.
Okay. First of all, thank you so much for this opportunity to the entire team of OXY and ICOG. Sunita madam, Parag sir, Sheila madam, Suvarna madam, Ashok sir, Sarita madam, as well as the conveners, Dr. Sampath Kumari, Dr. Durga Das, Dr. Supriya, and the coordinator for the day, Dr. Radhika, as well as to the 3 wonderful chairpersons that I have today, Dr. Meena madam, Dr. Sheila, as well as Dr. Hepzibah. Such a pleasure to be here today to be talking on an interesting topic as part of the certificate course of ICOG. I bring greetings from the Kannanur ONG Society, a society located at the northern tip of Kerala, doing a lot of good work, not just on the academic front, but on the social front too. We are talking on HPV vaccination today. I'm sure that it is not a new topic. We know a lot about it. So I thought I would just talk a little bit on the updates rather than getting onto the basics, because that is something that most of us already know. Now, getting into the topic, human papillomavirus, as you all know, is causally associated with close to 5% of cancers if you look at around the world. And they include cancer cervix, which is something that all gynecologists know. It also is causally associated with CA of the penis, with the vulva, the vagina, the anus, and the oropharynx. The way to remember would be vulva, vagina, and cervix for women, penis as far as the man is concerned, and then the anus and the oropharynx, which are gender neutral, applicable to both genders. There is also gathering evidence these days that HPV could have a role in conjunctival cancers also. The most important HPV-associated cancer, as we all know, is cancer cervix. Over 95% of cervical cancer seems to be associated with human papillomavirus infection. A little bit on the virus, because if you understand the virus, you understand the vaccines better. HPV genome encodes a regulatory region. There are 2 structural proteins, L1 and L2, and there are a number of early proteins ranging from E1 to E7. The early proteins play a very significant role in the replication of the virus as well as in carcinogenesis. L1 is the major capsid protein that we need to remember, and L2 is a minor structural protein. And it is the L1 protein that self-assembles into virus-like particles that forms the basis of most of the commercially available HPV vaccines today. HPV types and cancers. The most carcinogenic of all is HPV 16, which dominates the types causing cancer. The others include 18, 31, 33, 35, 39, 45, 51, 52, 56, 58, and 59. They also tend to cause cervical cancer. If you put everything together, 16 and 18 are responsible for almost 70% of the cancers. 6 and 11 are responsible for almost 90% plus of the genital warts that we see in men and women. Coming on to the types of HPV vaccine, as I already said, it is the L1 protein that assembles into virus-like particles, which is what induces the specific neutralizing antibodies and which is what forms the basis for the commercially available HPV vaccines. Cervarix and Gardasil are the two brands that we already know. Cervarix, as you all know, is a bivalent vaccine, covers HPV 16 and 18, the majority cancer oncogenic type of HPVs. Gardasil is a quadrivalent vaccine, covers 16, 18, 6 and 11. Both vaccines have got excellent efficacy as far as protecting from an incidental infection is concerned. And if you're thinking in terms of protection from vaginal and vulvar lesions as well as genital warts, then it is better to use Gardasil because that covers 6 and 11, as I already mentioned. Little bit more on HPV vaccine. The nonavalent Gardasil 9 has got a lot of significance and gives you a significant advantage when compared to the bivalent and the tetravalent ones. Now, Gardasil 9 would cover 16, 18, 6, 11, 31, 33, 45, 52, 58. And that would be good enough to protect 90% of HPVs, protect against 90% of HPVs causing cervical cancer. Now, if you take the bivalent and the quadrivalent vaccine, the protection would be somewhere around in 70% of the infections. Now, Gardasil 9 is indicated for anogenital lesions in men as well as in women up to the age of 45. Now, FDA has actually expanded the indication of Gardasil 9 to include oropharyngeal cancers as well as other head and neck cancers, which are caused by the specific HPV types that we have already mentioned. Now, what about the immune response to these vaccines? HPV vaccine, in comparison to natural infection, induces very high levels of HPV type specific antibodies. And because it is much higher than natural infection, that is why it is even indicated for those people who have actually been naturally infected by the same type of HPV. Because if you give the vaccine, the immune response is going to be better than what you achieve by natural infection. And even when somebody gets a natural infection, there is still a possibility of reinfection by even the same type later on. But if you give the vaccine, just because the titers are so high, the chances of reinfection can be reduced. So vaccination, definitely better, even in those men or women who have been naturally infected. Immunization in children who are less than 16 years creates significantly higher antibody titers when compared to older children and adults. That's why we tell vaccinate early, because the immunization ability is going to be, the potential is going to be better. When you compare Cervarix and Gardasil, there's been a lot of heated debate. Cervarix seems to induce higher antibody titers than Gardasil. And even if you chart the fall in the antibody levels after months and years after the vaccination, Cervarix tends to hold on to those antibody titers a little bit more better. Whereas Gardasil, on the other hand, there is a fall in antibody titers as months and years go on. The higher antibody titers which are induced by Cervarix would also mean that it can actually even help in cross protection, even against those HPV types against which Cervarix has not been originally designed to. So high antibody titers could actually make a difference and give some amount of cross protection against other HPV types also. HPV vaccination, whether it has actually changed the prevalence of HPV-related diseases. A similar discussion has happened after COVID came into being, and people who have been COVID vaccinated, people generally feel that even the other respiratory illnesses have come down because of the immunity that people developed after the COVID vaccine. Very similarly, HPV prevalence was compared in the vaccination era to that observed in the pre-vaccination period. And surprisingly, there was benefit noted even in unvaccinated women. There has been significant decrease in pre-malignant cervical lesions, a substantial decrease in genital warts, as well as this entity called juvenile onset recurrent respiratory papillomatosis, which is an HPV-related disease. Okay, so the prevalence actually has come down in this vaccination era. Now, HPV vaccines and the goals. In May 2018, WHO called for action towards elimination of cervical cancer. Their target was 90% of girls to be fully vaccinated with an HPV vaccine by 15 years of age by the year 2030. Okay, 90% of girls fully vaccinated with an HPV vaccine by 15 years of age by 2030 would mean that we can reduce the incidence of cervical cancer by almost 42% by the time we reach 2045. Fine. So this is what WHO thought. And good to know that by November 2022 itself, almost 125 countries have included HPV immunization in their national immunization program for girls. And another 47 countries have included it for the boys also. So this number is actually growing with more and more vaccines being available and a lot more companies coming into the market creating the new vaccines. Now, how has the vaccines evolved? Now, the initial dose schedule, which we all remembered in the earlier days, was if a girl is between 9 and 14, it is 2 doses. First dose and then another dose repeated 6 to 12 months later. For all those girls and women aged 15 plus, okay, 15 years to up to 45 years, it was 3 doses. A 0 dose and then another second dose at 1 to 2 months and then the third one at 6 months. Now, a large trial which is done in Costa Rica showed that the efficacy of Cervarix after 3 doses was comparable to those after 2 doses. Another study with Gardasil in India showed that a single dose of Gardasil provided similar protection against persistent infection of HPV 16 and 18 to that provided by 2 or 3 doses, telling us that if it's Cervarix, maybe 2 doses are good enough. If it's Gardasil, even a single dose could be enough. And that is why we have some revised vaccination schedules now, which are available, which seem to be more convenient. Now, in 2022, the WHO Strategic Advisory Group of Experts on Immunization, called the SAGE, now recommends it in the following way. Any girl who's less than 20, starting from 9 to 14 or 15 to 20, has the option to take either 1 or 2 doses of HPV vaccine. Any girl or woman who's more than 21 will require 2 doses. And it is better to space those 2 doses at 6 monthly intervals. They compared the immune response when the second dose was repeated after 2 months, after 1 month, and after 6 months. And they found that the immune response was much better and maximum when the gap between the 2 doses was 6 months. So anybody who's more than 21, give them 2 doses at 6 monthly interval. That's good. Anybody who's immunocompromised, somebody who's HIV positive, they are the ones who probably might benefit with a third dose, as was initially thought for all. Fine. Now, does vaccine help those who already have an HPV-related disease? Now, while the current vaccines are primarily meant to be prophylactic, they have been found to have benefits in patients being treated for HPV-related lesions also, which include cervical intraepithelial neoplasia, genital warts, anal neoplasia, and recurrent respiratory papillomatosis. Okay, so because it inhibits further disease, it prevents further spread of HPV. And this is a systematic review of 16 studies of women who are being treated for cervical dysplasia, and they got HPV vaccine perioperatively. And those women who received HPV vaccine perioperatively showed significantly lower recurrence rates of CIN 1, 2, and 3. Okay, so lower recurrence rates in vaccinated women than in the unvaccinated group for those women who received HPV vaccine perioperatively for those women who are being treated for cervical dysplasia. Now, the most important question, okay, are we thinking about only girls and women and forgetting our boys and men? Should we vaccinate our boys and men, which is a key question that we need to answer. In the early days, when the HPV vaccine stocks were very meager, now whether to give it to only girls or to give it to both genders, okay, the gender neutral vaccination program was always a dilemma. Now, giving it to boys at that point of time would have meant that even those girls living in areas with very high prevalence of cervical cancer won't be getting the vaccine. Okay, but now there are more and more companies in the picture. Okay, and that is making more number of vaccines, and the picture around the globe is definitely getting better. So whenever we think about giving HPV vaccine to our boys and men, that should revolve around 2 concepts. One is, does it help herd immunity? And number 2, what are the specific health benefits for that particular boy or for that particular man? Now, since HPV is a sexually transmitted disease, giving it to our boys and men would contribute to the herd immunity, which can actually in turn benefit our girls and women too. So that way it's good to give. Then this can also lead to complete elimination of the HPV types which are targeted by the vaccine. Now, coming on to the specific health benefits for the boy or the man who's receiving the vaccine. Genital wart is a very common HPV-related disease, which can be tackled with the vaccine. More importantly, oropharyngeal and anogenital cancers are the two most important HPV-related cancers in men. There are unfortunately no effective screening methods available yet for these cancers, so preventing them with a vaccine would be really, really beneficial. Now, before I finish, HPV vaccine in HIV positive individuals. Now, men and women living with HIV are, as you all know, more at risk for persistent HPV infections and associated cancers, including anal and cervical. They have a higher prevalence of HPV infection, a higher HPV viral load, and they are more likely to be infected by multiple HPV types when compared to another person who's HIV negative. HPV is more persistent if the person is HIV infected. So the older age groups have a higher prevalence of HPV than the HIV negative people. Women with HPV are more likely to be infected with HIV than an HPV negative woman. So that places them at a relatively high risk because of the associated immunocompromisation factor also. So WHO recommends at least 2 and preferably 3 vaccine doses if the person or the individual is HIV positive. So before I finish, my take-home messages. HPV is causally associated with 5% of the cancers across the globe, including cervix, penis, vulva, vagina, anus, and oropharynx, with some data coming up on conjunctival cancers also. Vaccines have a preventive role against them. Cervarix is a bivalent vaccine against HPV 16 and 18. Gardasil is a quadrivalent one with covering 16, 18, 6, and 11. Gardasil 9 is a nonavalent vaccine covering all those types which I've already mentioned. And Gardasil 9 should be able to protect against 90% of HPVs causing cervical cancer. Bivalent and quadrivalent should be able to protect against 70% of infections causing cervical cancer. HPV vaccination induces higher levels of HPV type specific antibodies, much higher than that during a natural infection. That is why reinfection chances can be reduced. Reinfection by the same type or by other type can be reduced if we actually give vaccine. So we need not even bother about the fact that this person could have been HPV infected even earlier before we think of giving this vaccine today. A significant decrease in pre-malignant cervical lesions and genital warts have been noted since the vaccination program started. The revised schedule would tell you 1 or 2 doses for all girls and women less than 20, and anybody who's more than 21 will get 2 doses at a 6-monthly interval, ideally, rather than an interval of 1 or 2 months. And before I conclude, we should all be thinking of vaccinating our boys and men too for their own health benefits as well as towards their contribution towards herd immunity. Thank you so much on that note. I hope I'm on time and I could finish. Thank you so much, everybody.
So that was a wonderful talk. Only as it's also mentioned in the chat box, Cervavac is now there, which is quadrivalent, and Cervarix is now not generally available. I think it's been.
Yeah, true.
Meena ma'am, the next speaker is Rajapriya ma'am, Dr. Rajapriya Ayyappan.
So are you sharing the CV or we'll go ahead? Dr.
I can share the thing. My first slide, I think, is the CV. Want me to do that?
No. I think I was waiting for our other chairperson. Okay, so it's a pleasure to invite Dr. Josephine Rosie.
I will be doing the talk ahead of her, ma'am.
Okay, right. Ma'am, go ahead. Yeah. So just let us. Dr. Rajpriya Ayyappan, she's MD DNB FRCOG. She's Managing Director, Om Fertility Center, Srinivas Priya Hospital in Chennai. And as of now, she is the IFS Tamil Nadu Past Secretary Patron, ex-COM member, OXI, Sexual Health Committee member, FOXI. ICOG Foxy RM course head in Chennai, MRCOG Part 3 examiner. Ma'am, over to you for your talk.
Thank you, ma'am. Thank you, Meena, ma'am, for that kind introduction. And actually, a nice topic, media influence. Media influence on adolescence is my topic, ma'am. Are you getting the full view, ma'am? Is my screen shared?
But it's not the full view.
Okay.
It's not in the slide show mode. So on the right
side.
right side. On the top right side, there's a slideshow. Yeah.
Oh, yeah, I think.
No, just below this. Below
Yeah,
this.
yes, ma'am. Got it. So, good evening to all of you. This is actually, I think, a very trending topic, I must say, how we are baffled about handling our adolescents and young at home when everyone is gadget struck. And we lived in an era way past where human connect was there. Emotions were flowing from all our special senses. We could just have eye contact and connect with the person. Our ears were sensitive, our eyes were sensitive. We could just speak nice words and listen to good words. We lived in a beautiful world where socially we were strongly connecting and keeping it alive. Then there was that millennium time of change when 2000 brought in a quantum change in where generations started changing. Then we got COVID struck. And with that, a lot of gadgets came into our day-to-day life. And now we live in a gadget invasion time where we just cannot escape its influence. Keeping that in mind, I don't think just adolescents are struck by this menace. It's universal. From young to elders, everyone is gadget struck. So what? We have to understand that over a period of time, it has had a lot of negative impact in day-to-day living. For instance, there's a sense of fear of missing out. Even at this moment, if there are 150 people or 160 people logged in, I'm sure a group of them will be going on scrolling their mindless scrolling of the gadget. And the sad thing is, it leads to a lot of peer comparison and makes us spend more than what we want. And of course, there's reels addiction, it affects sleep, the peer pressure influence, and a lot of things have been normalized. For instance, desensitization to violence has happened, early sexualization has happened, and this has become the new normal. And we have found that our young want instant gratification, and the device is more influential than what those surrounding that individual is. Now, over time, we've gone through serious health hazards and social hazards like cyberbullying, behavioral issues like shallow emotions. There's a bit of neuroplasticity and very short attention span. So today in a conference, the time given to us itself is just 15 minutes or 20 because that's our attention span. And of course, the emotional withdrawal. A person who connects with you in the social gadget, even if they meet in person, they may not be able to do the same. And how are we going to deal with it? End of the day, it has become part and parcel of our day-to-day life, so it is a necessary evil. A lot of other factors can influence our use of social media, like peers, parents, school, and above all, how that individual has inculcated certain values of life, particularly by the family. So here comes the role of media manners and cyber responsibility. Now, this is important because instead of shunning away social media, let's see how best we can capitalize on social media. There is hope. Help our people evolve. So this is a progressive society. We can't say, I don't need the gadgets anymore. But of course, anything gets better with respect and responsibility. Now, of course, the use of social media has opened up a new chapter in youth and adolescence. The world has become one. In their hand, they've got learning skills, newer opportunities. For them, no caste, no creed, no color matters. And of course, you find a lot of our young girls who want to do online shopping, and a lot of our young women as well. And things today is smartphone. So in the era of smartphone, it's become smart living, smart money. And how best are youth actually using all these different platforms of social media, from Facebook to blogging? They've created a new world with enhanced connectivity, diverse interests, world of knowledge, and they seek opportunities and they are willing to take that risk with the newer opportunities. And this is life today. And the future is going to be more tech struck because we're speaking more of robotic and artificial intelligence. So it is just that era of time where something else is going to dictate how you live your life. As it is, we all know when we are Google searching something, soon Google understands what you want, it reads your mind and exactly pops up what you are thinking in your mind. So the gadgets have already started reading your mind. So how do you protect yourself? Yes, it gives a lot of opportunity for creativity, a wider audience, and that's exactly what man wants. Man wants a large audience and a great appreciation. And when art was less appreciated, today a person from Chennai can, of course, display to Germany or London or whatever. So art, music, comedy, literature, photography, video blogs, practically everything with the various social media platforms like YouTube has given recognition and a good source of income for a great lot of our young. Now, of course, individuality and self-esteem is something which has to be developed, and the adolescent through social media seek their identity as an adult. So even a lot of us have found that matchmaking has become a challenge, and we are actually happier more than the arranged marriage platform if a love marriage happens. So it's also become app seeking and matchmaking and more opportunities to try which business platform works for their kind of suiting their lifestyle and time availability. Navigation is more easier. You can just, in a click of button, the youth find their way. They are great at navigating and understanding the weather. And language is no barrier. They just put the language app and they can practically communicate with whatever they want to seek as information. And COVID again has brought in this quantum webinar opportunities exactly. If not for COVID and social media, we will not be doing this webinar right now. So we've started having online courses, and adolescents actually, rather than a classroom, they like it. Like whenever they want, they can seek information. So higher education, what kind of profession they want to get it, what type of education they want, how much of online, how much of offline. All these have started happening, and they get good quality information through respected organization and experts, and that's what they're looking at. And even with business, no longer business has become the world of the adults. It's now become the world of adolescents and youths, and they have found varied opportunities. By the time they are in their teenage, they want to find out what their sources of income can be. And what we've understood, by the time they are 18 to 13 years of age, their best potential of their brain they use, and they become tech smart. And in fact, once they cross 30, 35, they're actually seen as a brain drain product. So today's adolescents are the source of the various new apps they have created, and they have made real good money through their novel thoughts in business. So this dynamic learning environment, when adolescents are into it and they are learning it, it needs to be encouraged. So they have been able to create a professional profile, understand trends in business, showcase their products, target advertising, and they know how to use the influencer to their advantage. Of course, we've seen how smart they've been when natural calamities and disasters have happened, where the youth have organized helps for Varda cyclones, when an earthquake or a flood happens, and they can reach out information like a forest fire. And we've seen so many movies which have used social media through their advantage. In the movie VIP, we saw how a young guy was able to connect with a lot of engineers and complete a project. Of course, while this is happening, and we are having sexual abuse and sexual violence knowledge for our young women and adolescents to tell this is good touch, bad touch. We had the movie Pink, where women started saying, if it's a no, then no means no. What about movies like Adolescence? They've also opened out how sexuality thoughts are different, and how in an young individual who doesn't know what is right and wrong, a young mind can be forced or exploited to different extents. And so to the Hindi movie called CTRL, where artificial intelligence is becoming human companion. The post-COVID, what are the advantages? Our young started getting stranded in different places. They started getting independent, and they learned their cooking art. So today our adolescents have become great baking people, and they started participating in contests, and they have greater health awareness. The minute some risk is happening in the field of health, they are more aware. So their vaccine promotions are happening. In fact, we recently had an HIV vaccine talk. So lifestyle, they explore diet options. So they are health conscious. They want to exercise. There are lots of movements, like even menstrual cup use is pretty high amidst the adolescents today. So we have to learn from them what is the new thing happening in the field of medicine. And of course, they do understand it is important to be having safe sex. And what about popular protests? This is an era of Kali Yuga where man is turning against himself, and a lot of chaos and commotion is happening in many parts of the world, and war is always brewing. But the young adolescents and youth are seeing how to make life meaningful, to live life. So we have social revolutions that Black Lives Matter, the Me Too movement, and while the elders are locked in the world of Facebook and WhatsApp, the young are actually into Instagram and newer apps, and they're able to appreciate diversity. They're able to see the various perspectives around them. In fact, LGBTQ is more accepted by today's adolescents than what it is accepted by the old school people. And marriage apps are actually rampantly in use these days because parents actually don't have the time or are not actually connecting as much they need to with their young budding adolescents. So the adolescents seek the support of the gadgets in their hand. It can be a mobile or it can be a laptop. They know how to get the information. They just need Wi-Fi internet. If any place you plan to holiday, the first thing they will ask is, do I have Wi-Fi there? Now, is it wrong? No. Young have led a lot of awareness for justice. We know about the Jallikattu movement, the Neduvasal movement, and plastic-free India, Swachh Bharat. A lot of progressive India is happening because of the young and adolescents, because they desire to do it. They can do so much of wonders for environmental protection. And that's exactly what was happening through Greta Thunberg in her climate justice activists. We have Malala, who made a huge female education activist movement. And all these people have reached out to their necessary audience through social media. They use the power of social media to be able to do it. So the individuals have to decide how they want to get influenced. And even all the political parties understanding there's a huge vote bank in the young who have turned 21, got their voting rights. So they are wooed equivalently through social media. And end of the day, it is very, very important for us to understand social media is here to stay. Social media influences the human brain. And we lived in an era where we were talking from our heart, but now we live in an era where it is going to be the gadget doing the talking, and our brain is controlled by social media. So how do we go about it? Balance online and offline life. Have a responsible usage. You need to find a way of de-addiction. There should be a gadget on and gadget off time. The family should inculcate these values into the adolescents. Have privacy settings. So whatever we talked about in the first slide, that this is a menace, we ensure that that menace doesn't affect the child. And we have to ensure that they're not truly impacted. The negative impact should be minimum. We cannot erase it. Give them the awareness of the potential risks. Critical thinking is important. No cyberbullying. We should not allow our adolescents and young to become victims of cyberbullying. And digital literacy. It is the schools which brought in social media in the hand of the adolescents. There's no doubt about it, because we had the online teaching programs, schools functioned online. And after that, it continued where a WhatsApp group was created, all their homework, everything is now happening through the digital media. So since schools have handed over the gadgets, and those gadgets which were given in their hands during COVID period has not been taken away, it has possessed their lives. So it's important also for schools to bring in digital literacy, how to respectfully use social media and not get harmed by it. And we also have to empower our government to bring in cyber police rules and regulations and help our adolescents to be protected. So with the support of the peers who are under the influence of social media, but of course, we saw a lot of youngsters using it with good influence. We have to have family, school, and of course, a lot of support by government to help these children see good, hear good, and talk good. So with togetherness, responsibility, and respect, social media influence can be programmed to do good for our youngsters. And that's the way to go. We have no escape from this media virus. So once struck also, we can still do wonders if we are exploiting it to our advantage. So with this, I'm closing my presentation, and Thanks for giving me this opportunity to ICOG and Sampath Kumari Madam.
Can I share my slide, Radhika?
1 minute, ma'am.
Yeah.
We will request ma'am to introduce you.
Yeah.
Hepzibah, ma'am. I invite Dr. Hepzibah, ma'am, to. Is that okay, Meena, ma'am? Hepzibah, ma'am?
I was missing her.
Yes, ma'am.
Hepzibah madam's message, she got disconnected. She is connecting again.
Okay, ma'am.
Okay.
So in the meantime, your talk, Dr. Rajpriya, was excellent, mind-boggling, very well presented. We know that it's the media is here to stay, and the best users are our adolescents, and we have to ensure they use it in the best possible way, not get addicted or not in the negative way, and save ourselves also from cybercrime.
Yes, ma'am.
So if
Thank
Dr.
you.
Yeah.
Meena is ma'am around? Ma'am, not you, ma'am, the other Meena, Dr. Meena Mahalingam.
Ma'am is here, ma'am.
Okay, thank you. Hepzibah, ma'am?
So I think I will introduce. Madam can conclude her talk because
Okay.
you're wasting time. Dr. Josephine Rosie, she is Department Head, Obs and Gynae at Madha Medical College Hospital and RI. MMCRI, Oxy Executive Committee member, Secretary Oxy Tamil Nadu Chapter 24, member of Oxy Adolescent Committee, member of ATNRCOG, IAG, WALS, IMA, CMs. So again, she is highly accomplished, having published international and national journals, a recipient of AICC-RCOG Traveling Fellowship in Eurogynae, and published posters in RCOG Congress 2020, teacher of UG and PG division courses in Oxford. And she has special interest in high-risk obstetrics, intrapartum care, gynae, endoscopy, and urogynecology. Over to Dr. Rosie, ma'am.
Thank you, Meena, ma'am. Can I share my slide?
Yes, ma'am.
One sec. Can you see my screen?
Not yet.
Okay, one sec. I'm just opening. Yeah. Now?
No, not yet.
Now, ma'am?
Yeah. Yes.
I'm starting, ma'am.
Yes, sure. Go ahead, please.
Yeah, a very good evening to everyone who's present here. And I first give my thanks to ICOG team and Sampath Kumari ma'am for giving me this opportunity. And I'm going to talk about school counseling in adolescence. So how are we going to proceed further? Whenever we are going for any counseling in schools, we have to concentrate on nutrition, exercise, and we have to teach the adolescents about their body condition, and then we have to tell things about the problems that can happen during adolescence like anemia, and we also need to explain them about hygiene. So whenever we take the adolescent stages, we do have to describe what are all the changes which can happen in girls and what are all the changes which can happen in boys. As you can see, the adolescent period is divided into early, middle, and late. In girls, when do the pubertal spurt occur? Breast budding and menarche happens between 12 to 13 years with body image concerns. Whereas in boys, the problem is quite a bit different because there also pubertal spurt occurs later. but testis enlargement can happen, and then there also can be certain voice changes, and they can show strength in sports. And then in middle ages, the problems that they can have is 14 to 16 years, they can have a regular menses in females with peer influence strong. There'll be more interest in relationship and emotional sensitivity. In boys, there are changes quite a bit different: rapid height growth and muscle growth, risk taking, peer dominance, and independence from parents. Whereas when you take the later stages of boys and girls, the girls try to reach a near adult physique. Emotional maturity will be earlier, stable identity, and they'll focus on their career more. Whereas their boys will continue to grow and identify the formation later, focus on career and independence. Emotional maturity will be slower in boys when compared to girls. Okay, nutrition. Why are we bothered about nutrition? Because nutrition is very critical, because the most amount of physical development happens during those years. Hence, a good nutrition is made sure to ensure healthy growth and development. So we always advise them to eat a healthy diet, which will try to meet the nutritional needs of a growing teenager. So what are we supposed to advise them? We can say, we can just not say don't eat all those things. They will automatically become aversive. So we should try to encourage them to take more, say yes to milk and milk products, preferably curd and paneer, green vegetables, fruits and cereals, and soups and juices, healthy juices. Regular meals with a balanced diet is mandatory. Whenever we are teaching them about what are all the things they have to take, we try and tell them, put forward and tell them which are all the things they can avoid. If they avoid, what is going to happen to them? So these are all the things that we have to tell them. Avoid burgers, pizzas, french fries, chips, and all those aerated drinks will be of problems which can cause to their health at a later period. So what happens when you take the foods which are not good in a good, which doesn't contribute much to your health? There can be more chances of obesity. Nowadays, when we take the overall statistics of India, there has been more and more of obese children who have been identified, and obesity is becoming a pandemic also in our place. So the advise them to reduce the carbohydrate to only 40%. Advise them to take, a person who's obese who comes and sits in the clinic, you can advise them to take 3 main meals and 3 snacks and cut down their calories to 1500 to 1600 per day. Never, always advise adolescents, never skip breakfast or meals. Eat breakfast within 2 hours of waking up. Why? Because you have to emphasize and tell them the importance, because whenever we sleep, our body is in a fasting state, then there is poor glucose and insulin metabolism. If it is prolonged, there will be poor metabolism of glucose, which will cause weight gain. And advise them to do exercise 30 minutes every day. So moving on, okay, how are we going to do exercise to cut down obesity? Choose preferably an outdoor game which is of interesting to you. Example, to practice a hobby which can be vary from person to person. It can be from simple badminton, volleyball, football, volleyball, etc. Try to involve yourself in school sports. Don't skip any dancing classes for tuitions, or encourage them to do an activity like cycling, swimming, jogging, brisk walking to help them maintain their fitness goals. Try not to take the try to take the stairs and avoid elevator. Walk to go to the bus stop rather than going, avoid bus or car, rather you walk yourself. Then swimming is an ideal exercise, and try playing games like softball or kick the ball exercises. So we teach them, this is a pictorial representation of what I said, to encourage them to do daily sport or activity and avoid being a potato couch, so that they put on more weight. Okay, now just that we have enlightened about what all the changes happens, now we have to tell the girls about their pubertal changes. So what is the normal menstrual cycle? When can it happen? Somewhere between 11 to 14 years. Normal cycle length is 24 to 38 days. Normal length can last up to 8 days. It can take up to 2 to 3 years for a girl's first period for her body to develop a regular cycle. During that time, whenever there is influx of hormones, the body is trying to adjust. So you have to reassure her, her that the first 2 to 3 years there can be some certain variations. So nothing to be panicked. In case of any abnormality, you go consult a doctor at the earliest. So as you can say, it doesn't remain the same for everyone. It varies from person to person, but the typical cycle range is somewhere between 24 to 38 days cycle. So this is just a pictorial representation of what are all the things that happens during a menstrual cycle. Everyone can put it in their OPDs and explain in case an adolescent girl has to understand the crux of it. We can put in a picture and then try to explain them what really happens. Okay, so girls, many people will come and have a doubt. So why am I growing dark hairs, or why is it becoming darker skin in the vulva and under the arms? So it is a normal physiology which happens where there is soft darkish hair grows in the vulva and under the arms. Later it becomes coarse and dark and curly. Hips start to grow wider and body becomes to look more curvy. Breast and nipples gradually grow larger and fuller. Nipples also become darker in color, and then which is followed by menstruation. So what are the things that we want to counsel is premenstrual syndrome, which can happen. The unlikely, some patients, some women, some adolescent girls can develop mood swings, tight breasts, food cravings, fatigue, irritability, and depression. We tell them to avoid junk foods, salty foods, caffeines, and artificial sweeteners. Tell them to sleep enough, drink enough water, and reduce stress. Dysmenorrhea can be a symptom because due to all those hormonal changes which happen. In case if it is affecting the day-to-day physical activity, we can ask them to take some mild painkillers at the early phase till the time they adjust to the menstrual pain. Then we can ask them to advise them we can also give them counseling regarding scanty and or profuse bleeding. Then androgenic features, yes, in case a girl develops more amount of pimples and excessive male pattern hair growth in the face, and they do have a hyper pigmented coloration over the around the neck, and there is abnormal hair loss, we have to teach them that those are all the androgenic features that they are having. In case it is affecting their outlook, they have to approach a doctor at the earliest. Okay, what are all the vaccines? As my previous speaker would have enumerated about vaccines, I am not going to go into the details, just that I'm just going to tell there are vaccines present for rubella infection and cervical cancer in the form of HPV vaccine. So already as it has been gone through, HPV vaccine can affect both boys and girls. It is present as 2 dosage or 3 dosage. It ideally should be given between 9 to 15 years of age. 9 to 15 years, if you are taking a HPV vaccine, it is 2 doses. More than 15 years, it comes in 3 doses. So pertaining to girls, now the boy should be taught about their male reproductive system, how the penis and about the testicles and the urethral opening and the prostate and what the urinary bladder does. Okay, the pubertal changes in boys slightly different. The testicles grow larger, fuller, and scrotum turns darker. Penis grows larger, longer with growth of hair at the base. Hair, yes, face, obviously facial hair growth is more. The boy starts developing a mustache, beard, sideburns, chest and underarms. Voice cracks, becomes deeper, and Adam's apple starts to develop. Sperm production starts in the testes, and ejaculation, including wet dreams, can happen. The shoulder and chest grow bigger, with bigger muscles generally develop for them. Emotional changes, yes, of course. Adolescence is the most crankiest phase of a human period. Transition from childhood to adult, more attractions, fantasies, mood changes. They become irresponsible, stubborn, and they search for identity and sexual development. They create a sense of crisis. Every parent who had an adolescent kid will be knowing about all those changes. Now, going to the pathological causes and what we are supposed to attribute or think over is anemia. Of course, anemia is the state in which there is decreased production of red blood cells or a disease, decreased concentration of hemoglobin, result decreased oxygen carrying capacity. So it is always advisable to know your hemoglobin level by a simple blood test. So in turn, for them to understand, it is always better any adolescent girl or a boy should anytime have a hemoglobin of more than 12 grams. That is the dictum thing we tell them. So there are various programs which the government has given us through, which is the Anemia Mukt Bharat program. They aim at 10 to 19-year-old adolescents should have provide them with weekly iron and folic acid tablet promoting awareness. The strategy is to 6 into 6, 6 by 6 by 6 approach, implementing 6 interventions, which is iron folic acid supplementation, deworming, fortified foods, alongside 6 institutional mechanisms to tackle anemia through a life cycle approach. So why is it very common? 7 out of 10 girls, it is very common problem. Though anemia affects girls, more malnutrition causes anemia in boys as well. What are all the problems that they can have? They can have simple tiredness, lack of concentration, poor performance, hair loss, and irritability. So the iron-rich sources, as we all know, green leafy vegetables along with non-vegetarians, chicken liver, mutton liver, and simple jaggery to dates can contribute to their anemia. Simple hygiene technique that we teach them is take bath, ask them to take bath daily, wash their hands before eating. Very important, wash their hands with soap after defecation. Menstrual pads should be changed every 6 hours. Then wash their private parts with water after urination. Then try to keep their inner garments clean, and clean habits will give them the confidence to carry forward. Of course, nowadays more and more amount of substance abuse has been coming. So we have to teach them smoking always is better to be avoided because it causes cancer, heart disease, early death. Avoid alcohol intake. Drugs are like taking poison, and ask them to stay away. Nutrient robbers, yes, of course, whatever you consume, even though you have very much good habits, these abnormal or substance abuse can cause your nutrient problems. So we try to tell them not to take all these things. So it doesn't only takes the nutrient away, but also it causes problems like physical dependence and addiction, health problems, social problems, morbidity and injuries due to violence, unprotected sex, motor vehicle accidents, suicides, homicides, and deaths. Next, we have already seen so many celebrities have been dying because of all these abnormal substance abuse and alcohol abuse. So we try to give them examples and teach them good habits and discipline to take them through. So always we ask them, adolescent, yeah, though it is a irresistible phase, they try to try to explore the new things. We always give them good examples, like Abdul Kalam sir has said, dream and transform your dreams will transform your thoughts, and thoughts will result in action. We give them nice, beautiful things to remember so that they don't go in the wrong way and they take the good way. Yes, why are we teaching them all that? We don't want our adolescent to get to have sexually transmitted diseases because of sexual practices which happen because of this drug abuse. So we always advise them, prevention is always better than cure. Always, it is always better if you have a small amount of infection, get treated earlier rather than not doing it. How HIV is not transmitted? Uh, So then we just also tell them that how HIV is not transmitted, which we advise them to tell that it is always better that you stay in
Sorry
a.
to disturb.
Time up.
Time
Okay,
up.
okay, ma'am, I'll just rush through. So we just also tell
Can
them
you please?
are very common. So we ask them to stay safe, always prevention by using barrier contraception. We don't advise them to use contraception, but still, in case they have some doubts, we have to tell them how HIV is transmitted. Then, are coming to the end of the session, we teach them. So, take home messages. We not only practice on nutritional health, physical health, we also tell them the importance of mental health, and we tell them about avoidance of substance abuse and avoid smoking, and all those good habits versus bad habits should be delineated to the adolescent. Thank you, Foxy team, ICOG, and Sampath Kumari ma'am for giving me this opportunity. Thank you, ma'am. Over to you, ma'am.
Thank you, ma'am. That was a very comprehensive um, uh, um, uh, uh, coverage of the, we have to tell our adolescents. Thank you very much.
Thank you, ma'am.
Hepzibah, ma'am, are you? Okay. So I think we will move on to the next session. Thank you very much, ma'am. Meena,
Hepzibah
ma'am.
madam is there. Radhika Hepzibah madam is there.
Ma'am, Epsiba,
Yes,
ma'am.
madam, you are audible.
Yeah, thank you.
Good evening, ma'am.
Yeah, that was a wonderful session. I thank the Foxy, and can you hear me?
Yes,
Yes,
ma'am.
ma'am.
Yes,
Go ahead.
yes, ma'am.
I think we are running short of time. Thank you for the opportunity. All the three
Not very clear, ma'am. Sorry, ma'am, it's not
Net
very
issue,
clear.
net issue.
Yes, ma'am. So, okay, ma'am. Thank you so much, ma'am.
useful.
Okay.
And thank you.
Thank you, ma'am. Thank you, Dr. Meena Samat, ma'am, and Dr. Epsiba, ma'am, for chairing the session. And we have wonderful talks. We'll move on to the session 2. We have the chairpersons. I invite Dr. Ashok Kumar sir, who is the Director, Professor, Head, Department of Obs and Gynae, Atal Bihari Vajpayee Institute of Medical Sciences, and Dr. Ram Manohar Lohia Hospital, New Delhi. And he is the Vice Chairperson 2025 and Secretary of ICOG 2021 to 22, and Editorial Board Member of Indian Journal of Medical Research, Archives of Obs and Gynae. And his interest is in maternal health, medical disorders, and high-risk pregnancy. He has numerous research papers and has edited 5 books and contributed 38 chapters in books. He's conducted 12 research projects of ICMR and UGC. I welcome Ashok Kumar sir. And I invite Dr. Meena Mahalingam, who has a special, who has done her MD, TGO, DPNB, MRC, OG, FIC, OG, MNAMS, and FAGE. And she's an associate professor of Obs and Gynae in Chengalpet Medical College.
Thank
and
you,
honorary
Radhika. We
secretary
can
of-
proceed. We are running short of time. Thank you.
Okay, she belongs to Urogyne Committee. Welcome. Dr. Meena, can you please introduce the speakers? Dr. Chitra, ma'am.
Yeah, thank you for the wonderful opportunity. Foxy team, ICOG team, Sampath ma'am, Supriya Arwari, and Dr. Radhika. So now it's my pleasure to introduce Dr. S. Chitra to have a talk on medical management of endometriosis. She is a founder, director, Janani Trichy Fertility Center, founder, director, Lalita Nursing Home, director, Shyamla Nursing Home, underwent IVF training at Singapore.
Madam,
And,
make it very
BM
short, madam. Similarly,
Yeah,
because we are running short of time.
Dr. Chitra to
Thank
give a talk
you,
on
madam.
medical management of
Thank
endometriosis.
you, madam. I'll share my slides now. 1 minute. Can you see?
Yes, ma'am, we can see. You need to make it to full screen.
I'm doing it. Okay. So my talk will be on medical. Thank you, everyone. Good evening. And thank you, the ICOG team, Dr. Sampath Kumari, Dr. Radhika Gauri, for having me here today evening. My topic for today would be medical management of endometriosis in adolescent. So endometriosis is also seen in adolescent. And one pathetic thing is many of us miss it sometimes. Endometriosis is the presence of endometrial gland and stroma outside the endometrial cavity. And stroma is usually more than the glands in the adolescent. Endometriosis is an estrogen-dependent and progesterone-resistant chronic inflammatory condition. And the disease is often unrecognized and it is ignored or mislabeled during the adolescent period. It frequently results in chronic pelvic pain. It causes adhesive disease. We all know the adhesions that we see in an endometriotic patient. And later, it causes infertility. The atypical presentation is more common because we don't typically see women coming with only dysmenorrhea during the adolescent age group. Early diagnosis and treatment usually decreases the disease progression and prevent infertility. So the prevalence is about 5 to 10% in teenagers, 25 to 50% of girls with dysmenorrhea and atypical pain abdomen of chronic nature present to us with endometriosis. The onset of symptom can be even earlier than 15 years. It is seen to about 50 to 70% of teenagers while they undergo laparoscopy for evaluation of chronic pelvic pain. The prevalence may be even higher if it is done by a person who is used to seeing endometriosis on laparoscopy than the young girls who do not recognize, sometimes the young doctors who do not recognize the pelvic peritoneal deposits here and there. So the standard diagnostic test is laparoscopy, and you have to look for peritoneal endometriosis, deeply infiltrating endometriosis, and ovarian endometriomas. And then you have to make a chart, that is the revised ASRM classification. Calculate the total points that you give on all the findings that you see everywhere, and then group them into minimal, mild, moderate, severe. So severe endometriosis again is not very uncommon in adolescent. So they say it is about 23% you see stage 3 and stage 4 endometriosis in adolescent. So usually whom we look for or whom do we think endometriosis is very common is in girls who have had menarche before the age of 14, who have low BMI, who gives a history of family history of diabetes and severe dysmenorrhea, and school absenteeism is very common in them. And if you go back and ask the parents, they will probably give you the history of neonatal uterine bleeding. So what happens is, if you don't diagnose it at the early phase, it will affect the quality of their life, it will affect their future fertility, and the period of delay may be long. For us to diagnose can be even up to 7 years. So from the history, examination, and imaging and biomarkers, you can diagnose endometriosis, and it's always a challenge to diagnose it when they are very young. So common clinical symptoms is cyclical or acyclical abdominal pain, irregular menses, and we all know about the Ds that are associated with endometriosis. So the physical examination, sometimes we will see there is an ovarian pathology or a Mullerian anomaly. When you do a rectal examination or an abdominal examination, you can identify these things. And 32% will have uterosacral nodularity when you do a rectal examination. And endometrioma and DIE is not very uncommon in adolescent age group. So when you go to an ultrasound, you will see an unilateral, bilateral, unilocular, multilocular cyst who have thin or thick septa, anything can be there. And low level internal echoes is the most common thing that all of us see. Kissing ovaries again is one thing that we will all identify on an ultrasound examination, and mobility will definitely be restricted. So this should give us a clinch on diagnosing endometriosis. And if you apply the Doppler and see the blood flow in the endometriomas, usually around the cyst, and the resistive index will be above 0.45. And transrectal examination can be done, and you can pick up DIE very commonly with this transrectal ultrasonogram. And CT is not very good in a pelvic endometriosis. It's more useful for sites like lung, scar endometriosis, or other things. If you want to demonstrate an endometrioma, then you will have to pack the vagina and then do the thing. So it's not very sensitive for the pelvic thing. But MRI is better in the other way. Endometriomas can be easily seen, and you can differentiate it from cystic teratoma very easily on an MRI picture. So you have to treat now. The goals of your treatment will be to relieve her pain. You want to arrest the progression of the disease, and you want to preserve her fertility. So what you want to do, you want to suppress the estrogen, because we all know it is an estrogen dependent disorder. You want to reduce the retrograde spill, because that theory always exists. We all know about it. You want to overcome the progesterone resistant. You want to give an anti-inflammatory effect, because the disease is there and the pain is because of the inflammation associated with the endometriotic nodules. Aromatase inhibition should be done, because you don't want more production of estrogen. Anti-angiogenic drugs can be used, because you don't want new implants to keep coming. And immunomodulation, because a lot of theories exist now about the disease being progressed because of the immunomodulatory effect in those women. So now what you have done, or what you know so far, is the therapeutic trials in adolescent girls have been tried with NSAIDs and OCPs very often to reduce the dysmenorrhea. And chronic pelvic pain they have dealt with, or they have used GnRH or Dynagist, and given us a good study to tell these drugs are very useful. Now looking into NSAIDs, the least effective dose should be administered either before or onset of the pain. So even before the period or the first day of period, you can ask her to take an NSAID so that she does not have pain. This can be mefenamic acid, ibuprofen, naproxen, or COX-2 inhibitors. But then the biggest side effect is the gastritis. So they'll be swallowing even without asking you, and they'll come back to you with gastritis associated with chronic pelvic pain. So you have to be very careful about it. The next choice that is available is the continuous contraceptive pills. So OC pills can be given continuously for 3 months. So it will give a very good relief of dysmenorrhea. But can we use estrogen and progesterone in young adolescents is a question mark. All of us have this in mind, especially in girls who are less than 16. So we are not very fond of using it. When we don't have any other option, then we start doing it. So they thought this endometriosis is an estrogen dependent disease. So should we really use estrogen and progesterone, or should we only stick on to progestin? So they started thinking progesterone is the first line of medical management for endometriosis. So that has been recommended by Eshere. Hormone contraceptive is level 2, level B evidence, and progesterone is level A evidence. So we have all switched over to using only progesterone for treating as a hormone treatment. So the newer progesterone such as Dynagest should be considered for first line empirical medical treatment for endometriosis, and it can be definitely used even during the adolescent period. So the progestagens that are available are medroxyprogesterone acetate. You can give it either as an oral or you can give it as an injection depot once in 3 months, or Dynagest, cyproterone acetate, norethistyrone acetate, or danazol. Only thing is the doses that we give should be a little on the higher side. So around 75% of patients receiving progestogens definitely will experience a good pain relief, and they are effective also in treating all the endometriosis associated pain. Progestogen act through many ways, like matrix metalloprotease. It will reduce that. Growth factors will be reduced. Inflammatory reaction will be cut down. So peripheral estrogen will come down. So it will definitely reduce the implant size. It will not promote new endometriotic implants to occur. The progression of the disease is reduced. So thereby the symptoms also come down. So it's a good drug of choice to treat endometriosis. So progesterone is considered to be as effective as GnRH analog or danazol, and norethistyrone should be given at 15 milligram per day. Medroxyprogesterone acetate again can be given, but only thing note the dose, starting dose itself should be 30 milligram per day, and it can be continued for up to 6 months, so 1 or 2 years. But then when you use it beyond 3 years, you have to be very much aware that there can be bone mineral density fall. So you have to monitor that and then decide what you have to change over. So you have to be careful about that part of it. Dynagest is again another molecule which has come up recently, or I should say the next best to medroxyprogesterone acetate. Dynagest is a 19-nor and progesterone selective 19-nor progesterone activity. It is 2 milligram per day, and it has an anti-proliferative, anti-angiogenic, and anti-inflammatory property. So it fights against endometriosis in different pathways. It has a good pain relief, and it is as comparable to GnRH agonist. Has minimal side effects and very good safety profile and tolerability, and can be used for a long time. It has been tried up to 5 years. So Dynagest acts both on the utopic endometrium as well as on the ectopic endometrium. It reduces cell proliferation, reduces bleeding, improves cell differentiation, reduces uterine contractility. Thereby, in the utopic endometrium, it reduces pain, and in the ectopic endometrium, anti-angiogenic effect because it decreases the VEGF, immunomodulatory effect is there, an anti-inflammatory effect is there, and pro-apoptic effect is also there. So by all these things, it will definitely bring down the pain, and the disease progression will be much lesser compared to other things. So Dynagest should be given as 2 milligram once daily in women with endometriosis, and it can definitely reduce the endometriosis associated pain. And if you try it after the laparoscopy, recurrence of pain following the laparoscopy procedure, or pain, the disease itself following a laparoscopy, is definitely reduced. So Visado study again emphasizes on its safety in adolescent period. So you can definitely try it even for adolescent age group. So GnRH is the next, GnRH agonist is the next drug of choice. Downregulation of gonadotropins is the mode of action of GnRH agonist. should be definitely used only in girls beyond 16 years. It can be given for 6 months. Thereafter, you should add back and give other things to support the reduction of bone mineral density. Side effects are like hot flushes, dryness, decrease in libido, osteoporosis. So you have to definitely have a add back when you give it beyond 6 months of time. So LNGIUS, all of us will have a question in our mind. Can we use this for adolescents? There is a separate new thing available. The size is smaller. That is called as JADIS, and it's specially designed for adolescent and nulliparous women. Definitely, this is also useful, and it can be considered as a second line of management in adolescents with severe dysmenorrhea and menorrhagia. The effect is multiplied if LNGIUS is inserted following a primary surgery. So it has a contraceptive benefit also. So you can tell them boldly about that. And effect is comparable to GnRH analog with continuation rate of 60%. So they don't come back telling you, I want it to be removed. So this is smaller in size. JADIS is smaller in size compared to our Mirena. So the newer drugs other than these are the GnRH anti, that is elagolix, all of us know of, progestogens, other newer progestogens, then SERMs and the progesterone receptor modulators. So elagolix, it's an oral gonadotropin releasing hormone antagonist. It's used especially for estrogen, endometriosis associated pain, pelvic pain. It's an FDA approved drug. You have to give a dose of 150 to 200 milligram twice a day, and it can be used very safely up to 2 years. And BMD reduction occurs when you use beyond that, and you have to be aware of that and do other things or stop the drug. So the next is the aromatase inhibitor that all of us know is the letrozole that we all that we use, and it acts as a central, peripheral, and local sites. It is used as a second drug of choice in endometriosis. It can be used. Use is limited due to hot flushes. And it can be combined with OCPs. It can be combined with GnRH analog and progestogen as well. And especially it's very useful in adenomyosis when you want to bring down the size of the uterus. With GnRH agonist, it lowers the that's what, bone mineral density, but effective for pain relief. And the next estrogen receptor modulators are the tamoxifen and raloxifene, which we all use. It can regress implant when you give it at 10 milligram per kg body weight in 40 to 50% of the patients. Risk of hot flushes and VET is very common with this, so it's not very popularly used. The next is the selective.
Madam, time up, madam.
Yes, I'll finish it in a minute. Asopresin is a common drug, and you have to give it at 5 to 10 milligram for up to 12 weeks to get a good result. Mifepristone is another drug which is coming up in now. Estrogen receptor ligands are there in the books. It's yet to come into human use. VEGF and MMP inhibitors, again, dopamine is being studied now in human to be used in endometriosis to bring down the size and the effect of it, because it can act on different ways. Statins again is being tried in endometriosis to be effective. You have to give a dose of 20 milligram per day for at least 6 months to have its effect. In spite of all these things, we cannot prevent adult endometriosis if we do not, even if we treat them well during the adolescent endometriosis period. Thank you very much for the opportunity. I finish with this. Thank you.
Thank you, Chitra ma'am. Very comprehensive, excellent discussion about endometriosis, starting from causes, risk factors, and the classification as well as the management. There are some questions, madam, which you could answer in the chat box. What about Sencroman by Dr. Poonam Gupta and Dr. Pooja Mishra? Is Selagolic safe in adolescent? Thank you so much, Chitra madam.
Yes, I'll answer them, madam. Thank you.
Thank you so much.
Thank you.
So for want of time, we'll introduce the next speaker who is going to elaborate on the surgical management of endometriosis. Can we have the CV? So now the next topic is Dr. Sahana Surpur has asked indications for surgery in adolescent endometriosis.
Radhika ma'am.
This will be done by Dr. Kalpana. Dr.
Radhika ma'am.
Excuse me, Dr. Kalpana will present later.
Okay.
Dr. Kunjan sir is here.
Chinmay ma'am is here.
Yes, I'm here. Do you want me to start?
Okay.
If you want, I can do mine first.
Instead of Kalpana, no, Dr. Kunjumon is here. He will be doing, and then next you can do, ma'am, because he's exchanged with Dr. Kalpana, ma'am. 5:15 slot.
Okay, no problem.
Thank you.
So
Thank you.
now Dr. Kunjumoidin sir will be doing the next topic.
Hello.
So he is gold medalist in MD and advanced training in laparoscopy, training in ART, and worked as chief consultant at Maulana IVF. And he is a joint secretary of IFS, president, Perintalmana OG Society. Over to sir to give his lecture now. Sir, Kunjumoidin sir.
Yeah, sharing.
Yes, sir. So he is going to do on fertility preservation in adolescent malignancy. Over to you, sir.
So am I audible?
Yes, sir. Audible and visible also, sir.
Yeah. So good evening all. Thank you for the opportunity. So the introduction slide might be around 5 years old. Currently, I'm with Birla Fertility and IVF, Calicut and Perintalmana. And the topic today is fertility preservation in adolescent malignancy. It is something very challenging because of the particular age. And also there are a lot of things we have to look for as they are progressing for their future fertility preservation. So the objectives of today's discussion, the cancer survival is high because of the lot of latest treatment modalities and the advancements in the diagnosis as well. The cancer survival percentage has gone up like anything, and that is a very, very good thing which has to happen for the mankind. And fertility is a key survivorship goal. So during the diagnosis or treatment of the cancer, they may not think about this fertility at all. But once they survive from the cancer and when they settle in the life, they always think about this. So it is the duty of the oncologist as well as the gynecologist, the ART specialist, to look into it. And fertility preservation must be discussed at diagnosis and revisited later. So it has to be first come out from the person who is diagnosing the cancer or advising the treatment for the cancer. Adults, adolescents and young adults, not many adults, their physiology and consent forms differ, and oncofertility teams reduce the delays to the treatment as well as it will avoid the delay in getting the cancer treatment as well. So gonadal toxicity, when we look at a big canvas, chemotherapy, radiotherapy, HSCT damage gonads. Basically, HSCT, that homologous stem cell transfer, that is not the one which is going to damage. The preparation for HSCT that can damage the gonads. And prepubertal, very often they are immune for many of the treatments. And the risk depends on the dose, what agent they use, age, and the field of that, depending on whether it is pelvic cancer or whether the radiotherapy is for somewhere else for the breast cancer and so. And baseline AMH or FSH or a semen analysis advised if they are cross the puberty. So the chemotherapy risk in female, that starts from the agents, right? That is alkylators. There is higher incidence of premature ovarian insufficiency. The HSCT conditioning. So many of the agents which are being used for the conditioning for HSCT, that has a lot of almost 80% risk for the premature ovarian failure. And the cumulative dose over many cycles and age, that predicts the incidence of premature ovarian failure. And it is basically always, if possible, if time is available, do the fertility preservation before surgery. Whereas coming to the male, alkylators that impair the spermatogenesis and freezing of the sperm, if it is postpubertal, that is possible. Use electroejaculation or TISA if unable to ejaculate. What I have seen, most of these adolescent boys are in the early adults. As soon as they're diagnosed as cancer, they lose all their motivations, and very often they won't be able to have erection and ejaculate. And we use electroejaculators or TISA. Both are possible. And prepubertal, then we need to preserve the testicular tissue because they may not be able to produce the sperms. So what are the radiotherapy risks and which is must in planning? The ovary 2G weight halves the follicular count, follicular pool. So even if they get the radiation of around 2, that will have the follicular reserve. And testis is very radiosensitive, and it is very, very radiosensitive. Most 99% of the people will go for azoospermia. Ovarian shielding, that is in case if you are giving radiotherapy to the pelvic area, ovarian shielding or transposition can be useful. And radiotherapy consult early for the ovarian transposition. So they have to plan early and get the ovarian transposition done, because it is a laparoscopic procedure that has to be done properly. And HSCT, homologous cell stem cell transfusion, special case. So busulfan and cyclophosphamide, that is the preconditioning for this particular thing. There is more than 80% risk. Urgent fertility preservation is mandatory in such cases, and dual strategies like ovarian tissue cryopreservation or oocyte cryopreservation, both can be done, and counseling about the long-term risk, because mostly, see, like in IVF, the patients, as soon as the embryo is transferred, they think they are pregnant, however much you counsel. But here the situation is very different, because they think the once we do the ovarian tissue transfer back or the oocyte thaw, so they think it is almost 100% they can get it back, but we have to counsel the possibilities of the thawing outcomes. So for a practical triage algorithm, if you have around 10 to 14 days delay between the initiation of the cancer treatment, then oocyte freezing is the best option. If it is urgent, that is there is no time available, or if it is prepubertal, then ovarian tissue cryopreservation. Pelvic radiotherapy is planned, that is at ovarian transposition still, then you need some time, at least a week time, and revisit. That has to be motivated properly. Once they are survived of cancer, they have to come revisit and look into the situation. So in the oocyte cryopreservation, established fertility preservation technique is the vitrification. So vitrification is very effective, and not only for the malignancy patients, the other for the social oocyte freezing also, people turn up in a large number nowadays, but at least 15 oocytes are required to result in a healthy pregnancy. And the random start protocol is most feasible one. You can start any day of the cycle, whether it is pre-follicular, post-follicular, or premenstrual, but the strategy will be different according to the presence of the dominant follicle. And target is, like I said earlier, it is almost approximately 15 oocytes. And letrozole co-treatment during the because the ovarian stimulation can increase the estradiol level. So the letrozole co-treatment, 2.5 milligram daily, that will be helpful in estrogen receptor positive cases. Coming to ovarian tissue cryopreservation, that is the only option in prepubertal or urgent cases. They have to start the surgery, they have to do the chemotherapy, they have to do the radiotherapy in a day or two. Then there is no other option like random stimulation and retrieving the oocytes. And laparoscopic harvest, slow freeze, that is the standard procedure. Ovarian tissue cryopreservation, it is not the vitrification, it is the slow freezing. And preserve adequate cortical strips. It is not the stromal strip, cortical strips. And document the retrieval site on the ovary. Ovarian tissue cryopreservation outcomes are generally, it is helpful to restore the endocrine function. And it is a world over proven thing, more than 200 live births globally. And spontaneous pregnancy also happen. That is the plus point. And ART pregnancies, that is the routine protocol, usual way of treating them. And success, that depends on age, tissue, and ischemia, whether you are causing ischemia, torsion, or cyst formation, or something like that in that particular ovary. And the caution has to be applied for the leukemia or hematological malignancies, because high reseeding. So when you put the ovarian tissue back, there can be the malignant cells can go back into the system in ALL and AML patients. And ovarian tissue transposition is contraindicated generally. Actually, it is OTC, that is cryopreservation, is generally contraindicated. And cryopreserved tissue for future in vitro use. We don't know what is going to happen in the future because a lot of developments are happening. So in future, this may be useful. But for the putting back into the patient, at present it is contraindicated, and advanced technologies are evolving every day. Coming to ovarian transposition, that is transposition the ovary to a safer location without compromising its vascularity or the pedicle. So moves ovaries away from the radiotherapy field. That is the main principle, and combined with ovarian tissue cryopreservation if the borderline doses are being applied, and risk of this transposition, the pedicle can get damaged, can get injured, and later on the ovarian cyst can be formed in that site. And always we have to track it, follow it up even after the radiotherapy for any damages or the torsions. And what about GnRH agonist to suppress the ovary during chemotherapy? It may help the recovery of the menstruation following the things, because the damage of the chemotherapy in a suppressed ovary will be lesser, and uncertain effect on live birth, and not a substitute for the ovarian oocyte cryopreservation, and it is only an adjunct in older adolescents. So coming to male fertility preservation, the post-pubertal semen cryopreservation is the gold standard, but very often this affected patient semen analysis the parameters will be poor. So we generally advise, if possible, if the days are available, at least 2 samples to be kept frozen. So multiple ejaculates are preferred. Electroejaculation and TSA, testicular sperm extraction, if the patient is having an ejaculatory problem, and repeat semen freezing is if time is available. It is same principle like multiple sample freezing. So this is the testicular tissue cryopreservation, that is almost experimental. So naturally we know the spermatogonial stem cell that progress to spermatogonia, primary spermatocyte, secondary spermatocyte, spermatid, and finally the spermatozoa. Bank the spermatogonial stem cell tissue before toxins, and lot of ethical formalities and protocols to be formulated, and families must understand the outcome. First human SSC grafts done, no sperm yet, means outcome. Trials ongoing globally, still experimental, and store for future use if some other developments coming into. Radiation dose, that again numbers, as I mentioned earlier, 2 gray, that will have the follicles, and high pelvic air RT radiotherapy, that will again increases the impact. Testis is highly radiosensitive, and use shielding and dosimetry. So the timing and coordination, fast track referral at a diagnosis or counseling for fertility preservation, random start ovarian stimulation protocol that will reduce the time, need not wait for the next menstruation, and have to not to postpone the surgeries if ovarian tissue cryopreservation or transposition is required. Have to finish it off early, and nurses can give proper advices to the patient. And endocrine health after treatment, premature ovarian insufficiency, if it happens, you have to give this HRT. And ovarian tissue transposition restores cycles or the hormones. Contraception may still be needed because the ovaries will be working if it is being protected properly, and monitor bone mineral density and the psychosocial effect. So the ethical consent and assent, adolescent assent and parent consent. So adolescent will be progressing. So what should we do when they becomes the mature adult? And the parent consent also involves differentiate established versus experimental techniques, that which has to be advised, because very often when we take the consent from the patient that it is trial or experimental, they always back out. Balance best interests with the autonomy and discuss cause and equity. So disease specific leukemia, avoid ovarian tissue transplantation, and lymphoma or solid tumors, the ovarian tissue cryopreservation or ovarian tissue transposition or transplantation is possible. Brain tumors, endocrine follow-up is critical, and rare gynec tumors, fertility sparing if possible, that has to be done. Male post-pubertal semen cryopreservation, prepubertal testicular tissue cryopreservation, it is experimental. Limit radiotherapy scattered to the testis and set expectations on recovery. The family's counseling, oocyte cryo, success comparable to adolescents. Ovarian tissue transplantation restores endocrine plus fertility. Testicular tissue cryopreservation or stem cell cryopreservation, no human births yet. Fertility preservation is safe, no adverse oncological outcome unless otherwise the hematological malignancies, if you take care. So SOPs and referral pathways have to be defined properly, cryostorage quality assessment and disaster plans if something happens, because these things have to be stored for long many years. Audit uptake, KPIs and outcomes, joint registries aligned with the ESCO, ESTRE, and now the ART Act of our country. So to conclude, the early discussion is very critical. Fertility preservation counseling at diagnosis. Choice depends on pubertal status, urgency, and treatment risk. Girls, oocyte cryo, that is most important. Boys, semen cryo. And intercity patients preparation, that fertility preservation is almost urgent. Leukemia, avoid ovarian tissue transplantation due to the receding risk. And fertility preservation does not compromise cancer care. So these are the key references. As time is over, I'm just pushing off. Thank you. Thank you so much.
Thank you so much, sir. Very, very comprehensive on fertility preservation in after malignancy. Thank you so much, sir. If so far no questions in the chat box, sir. Main thing they've asked is mRNA is the. Thank you so much, sir. Next, we move on to the next topic as we are running short of time. Can we have the CV of the next speaker? Dr. Chinmayi Ratta, who's the President, SFM Telangana Chapter, Chairperson, Foxy
It's
Perinatology.
okay, madam.
Yes.
We can move on. That's okay.
So over to the speaker, Chinmayi Ratta, to take over with her lecture.
Thank you very much, madam. And at the outset, I would like to thank Sampath Kumari ma'am for including me in this program. And the topic that I have is adnexal masses in the adolescents. So the adolescents, as you know, is the age group between 13 to 19 years. And whenever there is an abnormal enlargement that arises from any of the structures in the adnexa, like the ovary, the fallopian tube, or any of the surrounding structures, then that would consist of what is called the adnexal masses. They may be felt clinically while doing pelvic examination or visualized during radiographic imaging. Now, the important thing is the age of adolescence is an age when children are in school or in early college, and they're generally happy and healthy. So why at all would we suspect an adnexal mass in such patients or in such young girls? So they usually present with, abdominal pain. They may sometimes palpate some kind of a mass in the abdomen. Somebody might feel that there is a mass or a space occupying lesion there, or irregular periods. So those could be the common complaints why a girl would present to the doctor, and usually it is seen either as a clinical examination or an ultrasound would reveal the mass, or because of the symptoms we would do more investigative techniques, or sometimes it may present as an emergency, as in the case of ovarian cyst ruptures, hemorrhage, or torsion. So a high index of suspicion will be the first clue when a particular symptom in an adolescent will turn out to be what is an adnexal mass. But when you do a workup and diagnosis of an adnexal mass, there are certain challenges. It's not just like any space occupying lesion in any patient, because even diagnosing it is a challenge. So if you try to clinically diagnose something in an adolescent who says she's having lower abdominal pain, bimanual palpation is a challenge, because it's very difficult to do a clinical examination in adolescents, especially the ones who are not sexually active. And pelvic ultrasound by transvaginal route is also a challenge. So alternative routes have to be searched for. Then again, when you try to explain to them that there is a mass and there may be certain requirements for therapy, there are all these questions that come up. Already Kunjumoidin sir has addressed the fertility preservation in cases of problems in the adolescence. So the parents start thinking of so many things. The girls themselves start wondering, what is this mass? It is a tumor. How does it take to? So the clinical management will include not only managing the problem as such, but counseling regarding the future fertility options and the other aspects of life that get affected because of the diagnosis of such a mass. So there is definitely a challenge in the diagnosis, and as expected, there would be controversy in the management. So what exactly are these adnexal masses? The commonest things that we see are follicular cysts, which are just, simple functional cysts. They may also be corpus luteum cysts or hemorrhagic cysts in the ovaries. There may be some neoplastic conditions, and many of these neoplastic conditions are just benign neoplasms like the mature cystic teratoma or the dermoid cyst, serous or mucinous cyst adenomas. Fibromas and thecomas are generally rare in this group, but that is also listed in the differential diagnosis. Non-ovarian causes, that is para-ovarian cysts, paratubal cysts, even the broad ligament fibroids, hydrosalpinx, pyosalpinx, endometriomas, they may be part of your differential diagnosis of adnexal cysts. And in the malignant neoplasms that are common in this age group could be germ cell tumors, sex cord stromal tumors, or epithelial ovarian tumors, which are very rare in this sim, but they may happen. We should not forget that uterine anomalies may sometimes present as what is the suspected adnexal mass. You may realize later on that it is part of the uterine body and not just an adnexal mass, particularly like a rudimentary horn. And not to forget pregnancy complications, because that history also has to be sensitively elucidated. We should not just assume that because a girl is in that school or early college age, it cannot be a pregnancy related complication. So that history also needs to be taken. While looking at adnexal masses, as gynecologists and obstetricians, we are stuck to the gynecological and obstetrical causes, but not to forget that some extremely rare non-gynecological conditions like pseudocysts of the pancreas, ectopic kidneys, bowel, bone, or neurogenic masses can be sometimes seen in that area, as can be chronic appendiceal masses. So from a radiology perspective, one has to keep a differential diagnosis gamut completely open and think of all these possibilities when evaluating an adolescent for any adnexal mass. The symptoms, like I said, would be the first clue to the possibility of a mass, and that could be abdominal pain, which could be a persistent pain or sometimes cyclical. You may have acute pain in cases of, emergencies like torsion or ruptures of cysts. There may be fullness, bloating, heaviness, very generic symptoms. It may present as urinary complaints or bowel abnormalities. It may present as fatigue, headache, or general discomfort with nausea, vomiting, constipation. Fever and chills can be there sometimes. There may be backache or irregularity in the menses. So the history and clinical examination is very important in making the diagnosis of a pelvic mass. Now, how do we actually examine an adolescent? So per abdominal examination is possible, but suppose we are not able to do a per vaginal examination in girls who are not sexually active, a single finger PV very gently may be done, or a per rectal examination may supplement or replace a per vaginal examination. So we may do some imaging in which ultrasound takes a very important role, and lab tests like tumor markers. So ultrasound is really very, very important in the evaluation of an adnexal mass in the adolescents. And trans-abdominal ultrasound with a full bladder may give us some information. Transvaginal would be ideal, but as I've said earlier, it is a challenge to do this in young adolescents. So a transrectal ultrasound is a better replacement for a transvaginal ultrasound. A transperineal ultrasound is not very useful, and therefore the radiologists routinely recommend a transrectal ultrasound in case the vaginal route is not permissible. Whenever we need additional information in the ultrasound itself, a three-dimensional ultrasound would definitely add value. So we are assuming nowadays when you do an ultrasound, you're doing a volume study along with it, and otherwise color Doppler is a good supplement. You can use computed tomography, CT scan, or MRI in some cases, but not always required in evaluation of adnexal masses. So like I said, ultrasound is very useful, and you can see the uterus separately, you can see the adnexal area separately, and a functional cyst can be diagnosed as an anechoic area, usually unilocular, and the size is something between 3 to 7 mm. In fact, radiologists say that less than 5 centimeters, they don't even call it as a cyst as such, and this is usually due to an excessive response to the FSH. This looks big, and it sometimes causes a lot of worry, but it will resolve on its own. Most of them resolve on its own, usually an incidental finding, and therefore there is no recommendation to actively work upon the diagnosis of a unilocular follicular cyst. How would you make sure that it is a simple follicular cyst? Use color Doppler in addition to the plain 3D grayscale imaging, 2D grayscale imaging, so that you know that there are no hypervascular conditions there and the echoes inside are uniformly hypoechoic. So the wall thickness of the follicular cyst is usually thin, and you have a wall thickness of less than 3 mm, which clinches the diagnosis of a simple follicular cyst. The corpus luteum cyst, in comparison to a simple follicular cyst, has internal echoes which are a little more complex than a simple follicular cyst, and it does have a thicker wall as compared to the follicular cyst. Again, this is also common in the adolescent period and usually disappears on its own. So for the functional cyst up to 7 mm, there is no indication to do any kind of intervention. In fact, in some clinical studies, it has been said up to 10 mm also you don't need to do any clinical intervention. But once it is more than 7 centimeters, you may want to add a more sensitive investigative methods like the CT and MRI, just to be sure that you do not have any sinister problem going on. So if it's more than 8 centimeters, enlarging over time, any solid echoes, lots of symptoms, or severely persistent and not going down, then you may think of intervention. The theca lutein cyst, the name is now still controversial because some of them don't want to use this category. But when you have a cyst which has internal, septations and very sort of a mixed echogenicity inside the cystic component, but high levels of beta HCG, then you would classify it as a theca lutein cyst. Endometriomas, we've just had a talk on the medical management of endometriosis. So sometimes when this gets collected within the ovary, you have this typical ground glass appearance in that cyst, and that would classify as an endometrioma. The walls of the endometrioma are slightly thicker as compared to the simple follicular cyst. And when you put color Doppler there, you don't see internal flows and you don't see any masses. The common differential diagnosis of an endometrioma is that with an hemorrhagic cyst. And from a management point of view, to diagnose an endometrioma, of course, you can do a CA-125, which will be raised to some extent, not much more than that. But if you think it's a hemorrhagic cyst, you see the pattern of the hemorrhagic cyst changing over a period of time, because the contents inside will change because of physiological degradation. And the differentiation of an endometrioma with a hemorrhagic cyst is something that is important to note when you're making a report of an adnexal mass. Paraovarian cysts are seen separate from the ovary. So you will see a healthy ovary independent of the mass that you're seeing. And again, these are like very much like follicular cysts. The appearance is hypoechoic and smooth without any color enhancement or nodules or cystic or septations in between. So the tumors on the ovary that we are worried about in the adolescent area, as opposed to those which are in the adult, are of the germ cell origin, and some of them may also be malignant, and hence it is important that we have a good delineation of the characteristics of these tumors. So the mature cystic teratoma, which is the most common form of tumors in the adolescent period, is what is known as the dermoid tumor, whereas the epithelial tumors are less common in this area. So in the dermoid tumors, what we see is a hypoechoic mass with a hyperechoic nodule, which is usually called the Rokitansky nodule or the dermoid plug. And this may contain calcifications. It may contain other body tissues which give it a mixed hyperechogenic appearance. And the fat and the fluid there would give a differential, variegated appearance within the mass. So the importance of these tumors are that they are usually unilateral, but some of them can be bilateral, and they have tumor markers which help in segregating the type of adnexal mass that we are seeing. They can be diagnosed in early stage because they become very massive right in the beginning, and they are very amenable to treatment with chemotherapy. And if needed, some kind of surgery may be done, but a conservative surgery would work there. So when you actually diagnose the adnexal masses that are more than 2 centimeters in the pre-menarche or 8 centimeters after the menarche, with some tumor markers, with additional findings on investigative, diagnostic investigations like CT or MRI, or you have abnormal karyotype, which is seen in cases of dysgerminomas, then you start thinking of serious possibilities and the need for treatment therein. So these are the list of all the possible germ cell tumors that can happen in the adolescence of the ovarian origin. And there are specific tumor markers like LDH for the dysgerminomas, the alpha-fetoprotein for the yolk sac tumors or the endodermal sinus tumors, the alpha-fetoprotein and HCG in cases of embryonal carcinomas, or HCG itself in the choriocarcinoma. And these tumor markers will not only help us typify which kind of tumor we are dealing with, but also help us in planning the treatment thereafter. So this is a case I would thank Sampath Kumari ma'am for sharing it, because I personally do not do that much of non-obstetric imaging, and I wanted some clinical inputs from her. So this was a case of a 13-year-old girl who had attained her menarche about 6 months back prior to the clinical investigation, and she presented with a mass in abdomen. So again, you see, there was mass, but she presented with a mass in the abdomen and her UPT was negative, and the investigation revealed a solid tumor, which was then operated, and this was because of high AFP levels. It was suspected to be an ovarian malignant tumor, and that is what was operated, but she was kept on follow-up. How to find whether it's benign or malignant? In the oldest times, we were doing a morphological index, and nowadays we do the IOTA classification. And I would request everybody to go back and check into the IOTA classification, where you have benign features and malignant features, and this is available freely on the internet, the IOTA rules, and that can be checked. CT and MRI reserved for extremely limited cases. Management of ovarian masses or adnexal masses is either continued surveillance or expected management in most cases. Surgery limited to only cases that are suspected of malignancy or have any acute complications like torsions. So basically, you will wait and watch unless it is more than 10 centimeters or has high tumor markers, or in the premenarchal, there is an abnormal karyotype and you are suspecting some dysgerminoma. Not to forget unusual possibilities like ectopic pregnancy. And if it is an ectopic pregnancy, not only you have to solve that problem of the adnexal mass, but all the other problems that led to the unexpected pregnancy at that stage. Ectopic kidneys, uterine anomalies, bone masses, pancreatic pseudocysts, and old
Sorry to interrupt, ma'am.
So finally, the take to work messages is adolescent adnexal masses in the adolescent are mostly benign and resolve spontaneously. Torsion risk is high. Urgent surgery if suspected of an emergency. Germ cell tumors are the most common malignancies. The goal is to treat with preserving fertility and watch out for pregnancy related possibilities. Thank you very much. I'm sorry to exceed a minute.
Thank you.
Thank you, Chinmayi ma'am. It was an excellent presentation of usual and unusual causes in adnexal mass and the management. Thank you so much, madam. For want of time, we move on to the next speaker, ma'am. Thank you, Chinmayi ma'am. Excellent presentation. So we move on to Dr. Kalpana madam's talk on surgical management of endometriosis. Madam is the chairperson of Foxy Infertility Committee and gynecologist and fertility consultant at Guru Hospital, and she has been an invited guest lecturer in national and international conferences, and she has got many awards. Best Doctor Award by MGR University, Golden Excellence Award by European Continental University, Medical Excellence Award 2018 from Government of Tamil Nadu. Many credits to Madam. So over to Madam to take over the topic. And Chinmayi ma'am, as they want your presentation, the flow chart.
Yes, I'll see if I can just post it here. I will do that.
Thank you, madam. Over to Kalpana, madam.
Dr. Meena, can you see my slides?
Yes, ma'am, very clear.
Yeah. Thank you so much for the kind introduction. It is always my pleasure to be associated with Sampath Kumari ma'am, who had organized this ICOG webinar in association with Dr. Durga Das and Dr. Supriya Jaiswal, under the leadership of Foxy President Sunita Tandalwalkar ma'am and the ICOG Chairman Dr. Parag Biniwale sir. It is nice to have my dear friends, Dr. Radhika and Dr. Meena as coordinators for this webinar. So moving on to the topic proper, we all know that endometriosis, even now, it remains an enigma. The problem is the symptoms, severity of the symptoms do not correlate with the severity of the disease. The treatment plan should also be planned in such a way that in adolescent girls, mostly medical management is the first line of management. And in reproductive age group, surgical management should be the first line of management. But now the topic of discussion is surgical management in adolescent endometriosis. So when should we go for surgical management rather than medical management is the topic of discussion. Endometriosis, by definition, we all know that presence of endometrial glands and stroma in sites other than endometrial cavity is considered as endometriosis, and the prevalence is quite high, almost from 25 to 70% the overall incidence. And if a patient, adolescent girl, is coming with chronic pelvic pain or dysmenorrhea, confirmation by laparoscopy, almost 50 to 70% of teenagers have endometriosis. So the commonest sites are almost similar: adnexal pathology, or sometimes ovarian endometrioma, sometimes peritoneal endometriosis, either superficial or pouch of Douglas involvement, sometimes bowel, bladder involvement, and even ureteric involvement. Various theories have been put forward. The popular one is Samson theory, which was dependent on its normal physiology. Normally, the endometrial fluid spills on both tubes. So on the dependent position, we get commonly endometriosis. So that is favoring Samson's theory. But it is quite common in Mullerian duct obstruction anomalies also. So that again favors Samson theory. But the problem against Samson theory was endometriosis was quite common even in premenarcheal girls. So Mayer's metaplastic theory could explain this premenarcheal endometriosis, coelomic metaplasia, could be a reason for endometriosis in these patients. Sometimes we do see endometriosis in the scar site, which could be due to direct implantation of endometriotic cells, endometrial cells into the scar sites, or sometimes even in distant sites like lung, pleura, and also even in brain. So, Halban's theory, lymphovascular spread, could be a reason for this distant metastasis. Even though it's a benign disease, it behaves like malignancy. The next one is even all patients do have endometrial cells shedding on both tubes, but only 5% of general population do get endometriosis. And how does it happen is explained by immunological theory. These patients do have deficiency or lowered NK cell activity, which could explain about the presence of increased incidence of endometriosis in patients with altered immunity. Genetics also play a role. It is also said that 7% of first-degree relatives do get endometriosis. So if a patient has got a relative who has got endometriosis, we should think about endometriosis. And obviously, it is an inflammatory disease. Various markers like interleukin 1, 2, 6, tumor necrosis factor, macrophages had been documented to increase in the peritoneal fluid. The latest theory is altered microbiome theory, where it is said that endometrial cavity had altered microbiome. So because of that, peristalsis is affected. So the endometrial shedding towards peritoneal cavity is increased. That could be a reason for endometriosis. We know about the classification. Minimal is isolated spots, which is quite common. Mild is superficial lesion less than 5 centimeter. Moderate is either superficial or invasive lesions with adhesion, flimsy or adhesions in the peritubal or periovarian area. Severe is deep infiltrating endometriosis or large ovarian endometrioma, flimsy and dense adhesions, and sometimes frozen pelvis. How do these patients come to us, and when do we suspect endometriosis? Many a times it is cyclic, sometimes even acyclic. Chronic pelvic pain picture is also present in adolescent endometriosis. The history, when we ask from the adolescent girls, there is always withdrawal of social and sports activity because of the fear of severe pain, and prolonged absenteeism from school is a typical history we get from adolescent endometriosis. Always don't think about endometriosis in post-menarcheal girls. Even in pre-menarcheal girls, when the patients have typical symptoms, think about endometriosis. There is always a delay in diagnosing endometriosis because the symptoms are very vague. The adolescent girls usually consult various consultants, starting from pediatrician, gastroenterologist, urologist, and then finally come to gynecologist when we have a suspicion of endometriosis and further investigate the patient. It is almost 9 years cross. So there is definitely a significant progression of the disease when the diagnosis is delayed. That is the difficulty in adolescent girls, and sometimes the symptoms are not related to typical menstruation. The symptoms could be commonest symptom is acyclical or cyclical pain. Cyclical pain is only 30%. Vague symptoms like GIT and urinary tract symptoms, you should suspect endometriosis in these patients. When a patient is coming to us with acute pain, the other differential diagnosis which comes to our mind is either torsion, or we need to rule out Mullerian duct anomalies in these patients. So it is quite common. Almost 5% of adolescent endometriosis have Mullerian anomalies. Ultrasound examination will give us a clear clue about our diagnosis, and very rarely these patients can present to us with uterosacral nodularity or adnexal enlargement. So we have various markers. The sensitivity and specificity varies. CA125 has got a sensitivity of 85% up to, and specificity 4 to 100%, and peritoneal fluid tumor necrosis factor can also be. So when we are suspecting endometriosis in adolescent girls, even without confirmation of our diagnosis, Yashre also says that a trial of empirical therapy is acceptable in adolescent endometriosis. We can go ahead with the non-steroidal anti-inflammatory drugs and even oral contraceptive pills, which can be given. So if the patient is relieved, well and good. And sometimes if the patient is having severe symptoms, if she is elderly by more than 18 years, GnRH analogs can also be given empirically without any confirmatory evidence in our hands. So CA125 can be useful to follow the disease if we suspect, if the patient has got bowel symptoms, and if we are suspecting deeply infiltrating endometriosis or bowel involvement, transrectal ultrasound can be useful. MRI can be considered to think about MDA, Mullerian duct obstruction and anomalies, and also if we suspect GIT involvement or urinary tract involvement. So ultrasonography, it has been discussed in detail by Dr. Chinmay in the previous lecture. Ground glass appearance, nobody can miss the picture of endometrioma. So the first and foremost is medical treatment in adolescent girls, empirical therapy, even non-steroidal anti-inflammatory drugs and OCP, GnRH agonist for 3 to 6 months. If the patient is not relieved of symptoms, then you should suspect the Mullerian duct anomalies or other etiology which is not getting controlled with your medical treatment. So surgical treatment, laparoscopy, with laparoscopy, almost 70% of adolescent girls respond to surgical treatment. Sometimes we may miss endometriosis. So taking Culdi biopsy can give us a clue about the histopathological examination will confirm presence of glands and stroma in the biopsy tissue. Many a times it is a clear vesicular lesion, not like black typical lesions of adult endometriosis. And the Allen master windows are also quite common in adolescent endometriosis. Sometimes red flame lesions also quite common in so coming to surgical treatment in adolescent endometriosis, the typical thing is when there is a functional non-communicating horn with the endometrial lining could be a reason for endometriosis. In that occasion, we need to, the first line of treatment is surgical treatment, where we remove the non-communicating uterine horn, which is the reason for endometriosis. This is a case of uterine horn, accessory uterine horn, but there was no endometrial lining in the accessory horn. So in that occasion, we need not remove the accessory horn. You have to differentiate the condition and then proceed with the surgery. So the next common condition where surgical treatment is needed in adolescent girls is acute accessory and cavitated uterine masses. The patient typically presents with dysmenorrhea and chronic pelvic pain. Yeah, the ultrasound will help us to confirm the diagnosis. It is inside the uterus, and functional endometrium could also be seen. When do we think about acute rather than accessory horn? That is when the mass is under a round ligament and normal tubes and ovaries, and histopathological examination gives us some evidence, and the chocolate colored fluid also we get when we operate, and we rule out adenomyosis. This is a typical where the cavity is normal. The tubes, we can see it is below the round ligament and tubes. We can just remove that vacuum and then send it for histopathological examination. Many a times we do get a chocolate colored fluid, which again confirms that it is acum. So in addition to laparoscopic evidence, histopathological examination is also important. So this is another interesting thing. You should always think about it, where we have double uterus, and the one side of the uterus is obstructed by transverse septum. So in that occasion, the patient presents with hematometra in the one half that has to be evacuated, and the last one is endometriotic cyst. Why I have added it as a last one, because for endometrioma, surgical treatment is the last resort. If the patient is not responding to medical treatment, it should not be the first line of management, because it is going to reduce her fertility. Septum, I have not added my videos, but always have it in your mind. If a patient is having a septate uterus because of this peristalsis, there is a possibility of increased incidence of endometriosis in adolescent girls. But don't operate on uterus didelphi with double vagina, bicornuate uterus, or unicornuate with rudimentary horn, which is non-functional. In those cases, we need not operate. So the goal of surgery is to excise the lesion. Yeah, I'll finish it off, Radhika. So adhesion should be released. Pain relief is excellent. Other kind of surgical treatment could be needed in patients with pulmonary and also ureteric involvement. Sometimes if it is obstructing the ureter, bowel endometriosis, contrast barium enema will give us some clues. So first and foremost is the medical treatment. If the patient is not responding, think about other possibilities which is aggravating the disease, and correct the disease properly. And then to conclude, coping up with the endometriosis, which is a chronic disease, is an important component of management. Empirical treatment includes non-steroidal anti-inflammatory drugs and hormonal therapy. Definitive diagnosis and treatment is by laparoscopy, or sometimes even robotic is coming up, but constant follow-up is needed. Post-operative medical treatment is really needed to avoid recurrence in these patients. Thank you.
Thank you so much, Kalpana madam. Excellent surgical videos, and also covered all the acum and also uterine anomalies for surgical management, not only endometriosis. Thank you so much, madam. Very clear presentation. Thank you.
Thank you.
Over to you, Radhika.
Yeah, thank you, Meena. Thank you, Dr. Meena. Thank you for chairing the session. So we had a wonderful session with Dr. Chitra ma'am, Dr. Kalpana ma'am, Maidin sir, and Dr. Chinmayi ma'am. So now let's move on to the session 3. I invite Dr. Lakshmi Shrikande ma'am, who has a variety of case-based discussion on adolescent health. And ma'am, she's
I am here.
Yes, ma'am.
I am here.
Good evening, ma'am. Very warm welcome. And ma'am is the chairperson of Indian College of Obs and Gynae between 2022 to 23, and she's a national corresponding editor journal of OBG and Jogi since the last 8 years, and also national corresponding secretary, Association of Medical Women India, member of SAFOG Education Committee, vice president elect ISOPARB in 2016 to 17, and she's joint secretary of Indian Menopause Society 2024, and president of ISOPARB Vidarbha chapter 2019 to 21, chairperson of IMS Education Committee.
Let it be, Radhika. Let's start the panel. You invite the panelist here.
Okay, ma'am. So we have Dr. Shobha Gudi, ma'am.
I can see Suman.
Hello.
I can see.
Hello. I think you can move ahead.
Yes,
Hi, hi. Good
Yeah,
evening,
I can
Dr.
see.
Lakshmi. Good
So
evening.
happy.
Yeah.
Is
Yeah.
Dr. Janani also joined? I can see
Just
Suman,
move ahead.
Shobha,
Yeah.
Radhika,
Yes, ma'am.
and
Yes, ma'am. Dr. Janani, I'm here.
We are
hi.
all here.
Nice. Is Selva here?
You can start actually.
Okay.
Yes, Selva. Is Selva here?
Don't see.
Selva hasn't joined.
No
yet.
issues. No issues. No issues. No issues. We are
Yes,
having a really interesting case discussion. So
Yes,
I am straightforward going to the first case, and in the first case we are going to discuss the recurrent UTI and sexual health. So this is a case scenario that is 17-year-old girl presents with recurrent urinary tract infection, and she hesitantly discloses that she is sexually active with her boyfriend. and she's telling you that she has not shared this with her parents. So in this case discussion, our points of discussion will be how to take a confidential adolescent friendly sexual history and how to triage the safety and consent issues. Second will be how to distinguish UTI from STI and what test should be done. Third will be evidence-based management and prevention of recurrences. And fourth will be how to handle the partner notification. Gauri, don't put time as 30 minutes. For panel, it is 45 minutes.
Yes, I'm sure, ma'am.
Make your time as 45 minutes. Otherwise, we will be under a lot of pressure.
Yes, ma'am. We will.
And fourth point of discussion will be how to handle the partner notification, HPV vaccination, and everything. So here I am coming to my expert panelist, and just I request everyone to be crisp and concise how you will take adolescent friendly confidential history. Hello, Shobha, you can go ahead. Please.
Yeah. So very important to greet her, make her at ease, and show that you are open and non-judgmental. And without prying too much, you can gently ask if she is in an intimate relationship, and is she comfortable about the relationship? Is there any kind of force or pressure, or she is kind of very happy in the relationship? And then also educate her that sexual debut before 18 years is actually not
that
considered.
We will discuss, Shobha, that we will discuss as a
history
last
of
part.
Sexual history is we need to ask her about whether the symptoms are following the sexual act, and whether the partners are single or multiple, and also whether protection is being used with every act of intercourse, and if there are any associated urinary symptoms for her, because then we need to sensitize her that if we don't treat, it can cause permanent damage, and also, ascending infection. And once we are sure about the age, of course, we need to look forward to some kind of documentation and
No,
reporting
we
to
will
the
come to
local.
that.
We will
Shobha,
come to
Shobha,
that.
documentation
Okay.
is later on.
All
So
right.
here I just wanted to
right.
emphasize that in detail, you have to ask her sexual history, you have to ask her UTI
Yeah.
history, and you have to, this journey will answer in the last what is headaches and shades, and you have
Yes.
to ask her the recurrent pattern of her history. Whether this is
Correct.
related to the sexual activity, her
Yeah,
voiding
that's what.
pattern, and everything.
Sometimes it
And
is very
friends,
classically related to the act. Yes.
yes, post-coital UTIs are very, very common. Now coming to the what next? Suvan?
Yeah.
Will you go ahead and do physical examination? And what physical examination?
Actually, patient, she has already confessed that she was in sexual relation. So I would like to differentiate between if she's suffering from an STI. And for that, I will like to take a non-invasive that testing I will do. And I will also go for the routine urine examination to confirm if she's suffering from UTI. And accordingly, I would like to treat the patient if she's suffering.
Yeah, treatment we will come later. So
Yeah.
here I want to just emphasize that don't forget to do urine pregnancy test.
Yes.
If you feel that she is very sensitive, you can just do it and don't charge for that for urine pregnancy test. And first line tests are very, very basic. But don't forget to do the NAT test for chlamydia and gonorrhea. So now coming to how you will distinguish UTI from STI. I can see Radhika.
Yes, ma'am.
Because that is our basic crux.
Basic problem. Yes, ma'am. So, so if it's a UTI, it's more likely she might be having the frequency, urgency, as well as suprapubic pain. And usually she comes to us saying that she has pain in the abdomen, lower abdomen. And on doing a urine test, dipstick test, we can see nitrates positive and leukocyte estrase positive on dipstick, and it also has pyuria and bacteriuria on culture. So if they have pus cells and if they are more than 4 to 5, then we need to send it for a culture. And if she is symptomatic
No,
also.
we are coming to treatment part later on. Here, I just want to emphasize that if you really pay attention to your history, you can really make out whether this girl is having problem of UTI or STI or both UTI and STI together. Remember, you should not take that she is having dysuria means she is having UTI. It is not like that. Now coming to the management, Radhika, now you can tell them, now we are having different case scenarios. So if you feel that she is having uncomplicated lower UTI and you have sent culture, but definitely it takes 3 days. So now what you will do on that day? What you will give it to her?
So we have to start her on the antibiotic. Nitrofurantoin is the most preferred common one, and it's quite effective. And also we can try phosphomycin or our Septron, good old Septron trimethoprim, and depending on the sensitivities and local resistance. But the initial choice will be nitrofurantoin. And
yeah, phosphomycin is really good. You can just give 1 dose, 3 grams stat, and it will take care of that. But if STI
But it
is
should not
likely,
be the first line, I think. No, Lakshmi?
no, you are giving nitrofurantoin.
Correct.
But
And there is that
phosphomycin has,
sulfamethoxazole and combination
yes,
also.
that is yes.
Trimethoprim. Yeah.
That was if you are suspecting UTI. Shobha, now you can go ahead. If you are suspecting STI, what you will give it to her?
Yeah, I think it is very, very important to treat completely. And, broad spectrum cephalosporin, ceftriaxone 500 milligram. So this is not available for us, but we do tend to use cefoxitin. We tend to use cefepime also in such cases. And a full course of 7 days should be given. And we treat for chlamydia also concomitantly. It's very, very necessary. If the tolerance is less, then we do the antibiotic course one after the other. But it's important that full therapeutic dose should be given. So doxycycline 100 milligram twice a day for 7 days, along with the ceftriaxone or nitrofurantoin is very necessary. And one must follow up also to see whether we have achieved cure or relief of symptoms or not. And then, of course, along with this goes further prevention strategies, which you'll come to later.
Yeah, we will come later.
The
So
test
this is
of
the
cure
follow
is
up.
also necessary.
Yeah,
I think it's important to give a message of test of cure also. Correct.
Correct. So this is the slide for the audience that when you should call her for a follow-up and what you will be looking for, what Dr. Shobha was talking about. Because for STI, test of cure is not routinely required for chlamydia, but you can do her retest at 3 months to detect the reinfection. For gonorrhea, test of cure is recommended only for pharyngeal infection. If you are treating her for UTI, then you have to see whether there is symptomatic improvement within 48 to 72 hours. If there is relapse within 2 weeks, then you have to treat her accordingly. I am coming to Suman now. Suman, prevention is very, very important because she is coming to you with recurrent infections. So how you will prevent recurrent UTI in sexually active adolescent girl?
Yes, madam. If she is suffering from recurrent infection, then I would like to tell her about the behavioral measures. That is, she should
because this is the first line. Yes.
Yeah, she should immediately void after intercourse, and she should take plenty of fluids, and she should be aware that she should not use spermicides, and even diaphragm and also should not use. And regarding condoms, I should advise because it has gives dual protection, that is fully protected against pregnancy as well as it will reduce the STI risk. And I have to tell her about avoiding douching, and she should wipe her vagina from front to the back. This will be my advice.
Because these girls, they really read so much on Google. And if you ask every woman, they will give you history of vaginal douching. So you have to discourage that, and wipe direction itself, if you can educate them, it will really help them in a long term. Now coming to the prophylaxis, we are having postcoital prophylaxis, we are having continuous prophylaxis. So now I am coming to with the Radhika. Can you take this first, elaborate on? Let us go step by step, because when it comes to prevention, first is behavioral measures, Now, second, we are coming to the antibiotic prophylaxis. In antibiotic prophylaxis, let's first discuss postcoital prophylaxis.
So the immediate thing, for postcoital prophylaxis, we use single dose antibiotic immediately after sex. That is more effective, especially with women who have a UTI, and when it is clearly related to intercourse. So usually,
because this really reduces our total antibiotic exposure as compared to the continuous prophylaxis.
Absolutely.
But now tell me when you will give continuous prophylaxis and
So,
what continuous prophylaxis?
And we use nitrofurantoin 50 milligram nightly, or sulfur, methoxazole, the trimethoprim combination 40-200 milligram nightly for months if it is very frequent recurrence. So for that matter, even adults, if they have recurrences, we use this as a prophylaxis for up to 21 days even we can use. And it's best for the children because they are adolescents, best to use lowest effective dose and reassess at defined intervals. So we also have the...
There are non-antibiotic options, but they are not of, I will say ki they are having limited evidence, but you can try cranberry in adolescents. Now we are coming to the partner notification. So will you call for partner for evaluation? Who will call and who will not? Because she is having recurrent UTI.
Yes, ma'am. We should encourage her to bring her partner.
All the panelists agree with her?
Yeah, I think I strongly agree that,
yes.
Unless the
We
partner
should.
is present, we
Correct.
cannot give the correct message for safe sex practices. We cannot
Yes.
rule out coercion and the element of abuse
So
if it is built
we
inside.
should, if he has come, it's well and good. If he has not accompanied her, we should encourage her to bring in partner for detailed counseling and testing.
So every aspect
now,
of
Shobha,
care
your
will be
favorite
related
question.
to partner's presence. Yes.
Yes. Now, Shobha, coming to your favorite question. Now you have to counsel her for pregnancy prevention, HPV vaccination, and hepatitis B. So just elaborate.
Yeah. I think once the acute symptoms are, subsided and she feels a little better, I think at the same time she will not take so many correctional, counseling advice, etc. So we need to strictly call her back and then talk to her, and we have to pursue this. And when she comes back, we have to talk about contraceptive methods, and it's preferable that the partner also comes, and we need to give a strong message that all contraceptive methods which are used for adults have equal safety in adolescents as well. And we need to alert them that there has been an early sexual debut, and vaccine goes hand in hand with safe sex practices. And therefore, it is a lifelong protection. And she should very seriously consider HPV vaccination. And we must tell her about the safety and, the cost effectiveness of the HPV vaccine. And also the other infections which go with sex, so like hepatitis B, for example. Now, what we need to convey here is that with freedom for sex, we are not being judgmental at all, but we need to convey that there is a huge responsibility which goes along with the choices that they have made. So, so that is what we need to convey. Yes, Lakshmi.
Very well said. Very well said. Now coming to the legal dilemma. Janani, I am coming to you after we discuss these clinical aspects for these headaches and sheds. So you can give the comment on the the psychosocial element of this case. Now there is a real legal dilemma for the treating gynecologist. So just quickly tell me about the conflict between POXO and our AFSC, that is Adolescent Friendly Health Services. Suman, how you will go with this conflict? Because on one hand, it is mandatory.
One hand, we have to, one hand there is POXO and other hand is the ethical practicalities. So in India, for the POXO Act makes reporting of any, Madam, can I go back? Yeah,
I will go back. Yes, please.
So in India, any this POXO Act tells to report of any offenses if it is under 18, that is mandatory. And suppose a girl comes to us, and she's 17 years old. What to do? One hand, we have to keep the secrecy that she has undergone sexual intimation, and other hand we have to look for the POXO Act. So it's a big dilemma. So this creates actually a legal obligation. So we have to tell the adolescent when she comes in with the first visit that there are certain things which will be confidential, but certain things it has to be reported. So she has to be, from the first hand, she should be told that these are our responsibilities. And then we have to ask if the adolescent girl tells us that this was we both had agreed to the sexual act, then also it is our duty to report to the police reporting we should have to do, or we have to approach to the AFHC referral, that is adolescent friendly health
Health clinics. You
center.
can really refer to
Yeah.
them, yes, for further care.
But if there is sexual, if you think that it was sexual assault due to coercion or the partner was adult, then we have to report to the police. This is mandatory.
Yes. So in the beginning only you have to tell her that I can't keep certain things as confidential. It is my legal duty to inform the police. And then you go ahead. Of course, patient comes first. You have to treat her, but simultaneously you have to report. That is your duty.
Yes.
Now coming to the documentation, Radhika.
Yes,
because here documentation is very, very important. She is under 18 years of age. So what exactly you would like our audience to tell how they should document, what they should document?
So
because we are very poor in documentation.
Absolutely. So we need to take a detailed history, and according to this, there is we have this abbreviation, so we can use this, and we need to document it, and whom we saw alone, and whether who at the date and time, and I mean the whom the girl saw, who she met, who was the partner, and what time and date also. Exact wording of the adolescent report should be used, and the examination findings, vitals we should use. And we should also order the urine dipstick, urine culture, urine not and all these things we should record. And UPT also, urine pregnancy test we need to take. And we have to document the treatment started, the drug, the dose, the duration. All these has to be documented clearly, and what was the rationale for empiric therapy is given. And then the counseling regarding confidentiality limits. We should explain to her that at some point we might have to.
So you have to document. We are on documentation. What counseling you have given? You have given contraception, and you have to document everything in detail. And if you are reported under POXO, you have to record the report details as well, to whom you are informed, which police you need, and the child protection referrals made. This is binding. Now I am coming to the Janani. Janani, now I am coming to you. Now she's telling you, don't tell my parents. So what you will tell we clinicians, how we should go about it?
Lakshmi ma'am, 1 second ma'am. Can you please go back to the previous slide?
Yeah.
We'll just take a, because that's very important. Recently we had some cases like that. Can I take a picture of it? We can post it in the group.
Yeah. And share in group also that PDF. Yeah.
Yes, ma'am. Thank you, ma'am. Thank you.
Yeah.
Yes,
Janani, now I am coming to you. Now here there are so many issues because she is under 18 years of age. So now your take on this case.
Yes, ma'am. So one thing we are expressing to the child is we're establishing a rapport, and we're also trying to tell the child that they're safe with us. So we can say sentences like, I understand, I will keep what you say private unless I think you or someone else is in danger. Right? So risk of harm to self or others, we have to report. And because you're 18, there are legal responsibilities that I have to follow because I feel a crime may have happened. Right? And yes. Yes, and also to mention to the child that the priority that we have in our mind is the child's health and safety, and that we need to look through certain treatments and tests to ascertain our diagnosis, or and refer for counseling if required.
Yeah, here I would like to ask anyone who can answer. Now she is telling you, don't tell my parents. But when you will disclose the information to the parents or the guardian?
When she's under 18. We have to.
She's under 18.
Yeah.
So what
we
are the
have to-
circumstances?
I think if there is a risk of
Yes, Shobha.
pregnancy or a serious
Yes.
infection, if there is a
Yes,
risk
well-
of pregnancy or serious infection, which might put her health at risk, or
Yes,
if we
when she
suspect any domestic abuse, if there is
Coercion,
required
yes.
coercion, if there is requirement for
Coercion.
informing the law authority, I think the legal guardian also has to
Because
know.
once you are informing POCSO, I mean,
Yeah, we have.
parents
I think.
automatically comes into picture.
Yeah, so we should be the ones to tell them, and
Yes.
also
And we should
actually
tell the adolescent, yes,
correct, that you are
that
helpless
it
in
is,
this regard. Yeah.
yeah, it is in her best interest that we have to confide in her parents because her health is in danger. She has
Correct.
already come to you with
But
recurrent
suppose,
UTI.
but suppose her symptoms are mild, and then the
Yes.
partner is also cooperating, and both of them are very cordial.
You
I mean,
need
they
not.
accept every
Yes.
advice. Then the next step would be to give them full information about safe sex and inform them that there is a POCSO Act. Show them to the Government Gazette of India, and because it's very easily available on the mobile screen. The moment you put POCSO Act, Gazette of India, it is seen on the mobile screen. So that you can show it to them. They can also download and get convinced that in our country, it is a legal offense to indulge in sex before the age of 18. So
yes,
they can postpone their debut to more than 18, encourage them to continue the relationship and friendship, and tell them it is only a matter of time. That is how I think supportive environment, if we build, then probably we will emerge from it and they will go away with good messages. We also need not inform the law. So, I mean, we can prescribe then antibiotics, something like urinary tract infection. And probably that is how I look at it. That is how I practice. Because the moment I write
Yeah,
it
we
as a
have to
sexually
treat her.
transmitted infection, I become legally bound to inform it to POCSO. So these are
That is your
things.
legal duty.
Yes,
You
it becomes.
can't avoid your legal duty because then it is a punishable offense if you don't
Yes, for the
inform under
doctor
POCSO.
also, for the gynecologist also. But if
Yes.
it is a mild infection and if the couple is very forthcoming and they just go away, and these are some ways out of avoiding the legal hassle. If it is a very mild case where they are very receptive to your advice and they completely understand and they tell you that they will follow the law, that is something, that is one way of looking at it. But if
You are going to the
yeah,
patient friendly module. So that is case to case. But what I want to emphasize is that do tell them that they have to follow the safe sex practices. Do counsel them for contraception. Do tell them about HPV vaccine, hepatitis B vaccine. Do call her partner for partner counseling about safe sex practices, what Shobha is repeatedly emphasizing. And also, if you want, you can treat both the partners. If you are suspecting STI, you have to treat both the partners. Right, Shobha? So to summarize first is,
absolutely, both have to be treated. Yes.
yes, because we are having another interesting case. So friends, don't treat dysuria reflexively as UTI. Don't jump because she's complaining of dysuria means she's having UTI. No, it's not like that. Dysuria can be a symptom for STI also. Don't promise absolute confidentiality without explaining the legalities, what again Shobha was repeatedly highlighting. Don't ignore the need to assess for sexual coercion or abuse that you have to ask her. So the key takeaway from this first case is that you have to do the screening, you have to do the relevant test, you have to give her the treatment for UTI. If you are suspecting STI, that if she is NAT positive, you have to treat her. Don't forget to counsel her for the prevention. Here, behavioral methods come first, then comes the postcoital prophylaxis, and then comes the continuous antibiotic prophylaxis. And be legally safe. first and foremost is protect yourself. Now we are having another very, very important case. This is just a 14-year-old girl. She comes with fatigue, poor concentration in school, having heavy menstrual bleeding. And she has come to you with hemoglobin of 8 gram. When you further explore, she admits to restrictive eating due to poor body image concerns, which is influenced by the social media. So, Janni, would you like to pitch in first before we go to the clinical aspect?
Soma.
Because she is giving a history of eating disorder.
Yes. So once she gives you a history of eating disorder, it's important to try and look at all the main issues, like since when it has started, how does she do this? How is she just restricting her intake, or is there purging, or is she using any laxatives? Are we looking at amenorrhea? What are the other symptoms that we have? Is we're checking the BMI, we're doing a physical examination. It's also important, at least from our side, to also probe into other comorbid psychiatric issues like anxiety. Are we looking at some obsessive traits? Are we looking at body dysmorphic issues? Is there bullying secondary to which she's doing this, family dysfunctionality? These are all things that we will look at, ma'am.
Yeah. So from clinic, so in this case scenario, basically I want to discuss the 4 points, that is the screening and management of adolescent anemia, interplay between nutrition, body image and menstrual health, the counseling strategies for adolescent and her parents, and need for multidisciplinary approach. Because in this case, we are having two problems in our hand. First is heavy menstrual bleeding and second is inadequate eating. And both these issues are leading to her severe anemia. So what are the red flags? She has come to you for the first time, Suman. So just quickly, can you tell what are the red flags which you will be very, very careful during her first visit?
If she is suffering from severe pallor or she complains of syncope, there is postural dizziness, she is suffering from tachycardia, chest pain, or she is breathless even at rest, then this is very, very serious condition.
Yeah.
And we should look what is the cause of it. And then if she is telling that she is rapidly losing weight, there is bradycardia, orthostatic hypotension, and she is not eating properly, that may be the cause of being amenorrheic, and there can be some electrolyte abnormalities. And if she gives history of easy bruising, bleeding elsewhere, history of family bleeding disorder, then these are the things which we have to look into and try to find out the cause of our why
Because as a clinician, yeah, very well said, Suman. As a clinician, we are having 3 issues in our hand. First, because of her 8 gram hemoglobin, that whether she is having hemodynamic compromise, so you will look for that. Second is her eating disorder, whether how serious it is. And third, you can't ignore the coagulation disorder as a cause of her HMB, because that is the second most common cause for adolescent HMB. So these are the 3 issues which you have to tackle in your first visit. So what is the differential diagnosis, Radhika? You just cannot assume.
Yes, ma'am. So if it's heavy bleeding, we should think of anovulatory cycles, which are quite common in adolescents.
Because she is just 14 years old. Yes.
Yeah. And then the bleeding disorders, the usual ones, von Willebrand's disease, platelet function defects, when Glanzmann's thrombocythemia, thrombocytopenia, those things should be considered. So we need to take a history relating to that, whether she has this bleeding gums and those history leading to that. And then other gynecological causes which are less common also need to be considered, like structural uterine lesions, foreign body, pregnancy complications also we need to consider. And then what are the other contributors to anemia, which are the poor dietary intake, malabsorption syndromes, helminthic blood loss, hemoglobinopathies, and chronic inflammatory diseases should be considered.
And don't forget to do urine pregnancy test even if she is 14 years old. Because pregnancy complications you always have to consider once any adolescent girl comes to you with bleeding disorders. So what are the first line tests? Now who will answer? Well, you can't order all the tests which are there in your armamentarium. You will have to prioritize what test you are going to order. Shobha, would you like to answer?
Yeah, I think that the basic CBC, as you have put it up, is extremely important, and the peripheral smear because it will give you the degree and type of anemia as always. Maybe serum ferritin is also valid, and as you said, pregnancy test, baseline TSH is very much necessary. Well, I would like to put her on progesterone therapy, and if she is responding very well, I think that I will hold on to the coagulation tests right
No,
now.
we will come.
Yeah,
You
because I
can,
think
but
there are no other symptoms of bleeding from anywhere else like gum, etc., epistaxis, etc.
correct.
We can hold it.
Absolutely.
But yes, one thing we can do is tool for occult blood, and we can deworm her. That is important. But what is very striking here is that we need to sort the eating disorder, because that seems to be the number one problem for adolescent today. So anything related to eating disorder, I think we must take it up. And as you have put up some basic metabolic
Scoff and eat. I will tell
yeah,
in great detail.
yeah,
They are very,
yeah,
user-friendly things
yeah,
which
yeah.
every gynecologist should have in their OPD, and it hardly takes 3 minutes to complete that questionnaire. So this is the clinical immediate trials because she has come to you for treatment. So you have to start the treatment on that day. And here again, we are having many issues. So first, let's discuss the treatment of HMB, then the iron deficiency anemia.
Yeah, can I say?
Yeah, please.
Yeah. So she has two things to be treated. One is she's anemic, and other one is she's having uh, heavy menstrual bleeding. So first we'll like to tackle with the heavy menstrual bleeding, and that can be done by using any antifibrinolytic, especially tranexamic acid. That is dose will be 15 to 25 milligram per kg body weight. It may be 2 times or 3 times daily, but it has to be given for 4 to 5 days. And we have to be very cautious if patient has family history of thrombosis. And then after that, we can put her on COCs. And according to ACOG guidelines, the monophasic COC can be given every 8 hours if she is bleeding very heavily. And when the bleeding is controlled, we can give the normal low dose OC pills for 3 months. Not more than that, because she's
Now,
adolescent girl.
my question to all the panelists, she's only 14 years old, because this question is being repeatedly asked to me in every forum whenever I say ki you can give COC to 14-year-old girl. How comfortable you all are and how convinced you are in prescribing COC to a 14-year-old girl? Give an emphatic message to all the audience that it is very, very safe.
And it is given only for a short duration, madam. It is
Yeah, you are not giving her
Correct.
for years together, but
Yeah, in a stipted dose to control that particular cycle, it is possible to use, and it is very highly effective. And it will
yes,
stabilize the endometrium very well. There is no other
correct.
medicine which stabilizes the endometrium so well and allows us to then put on progesterone only therapy from the next cycle. So it will give you a very good
Benefits,
control of the uterine endometrium. Yeah.
Benefits are far, far, far more than the whatever risk you can think of. So please go ahead and give COC to this girl. It will really control her HMB. It will improve her quality of life. It will improve her school performance. So my answer to this is you can go ahead and prescribe COC to this girl for HMB. Now, how you will treat iron? Because you have to treat everything simultaneously.
Can I again tell?
Yes,
Yeah,
ma'am.
please go ahead, Radhika. Yeah.
Radhika, yes, you can.
Oral line is the first line. So for most adolescents, and we need to give them the the iron with elemental iron 60 to 120 milligram. So ferrous sulfate is a common one, and we can give one tablet once or twice daily, depending how she's able to tolerate. And we need to continue this for at least 3 months after HP normalizes, because we need to improve her stores anemia, the iron stores. And then we should also counsel for the side effects and whether she's able to tolerate the iron, the constipation, black stools, and she should not take it with tea or coffee. and it's best to take with lemon juice or orange juice, which are rich in vitamin C. And also we need to monitor her reticulocyte rise within 7 to 10 days and the hemoglobin response at 2 to 4 weeks. So if oral iron is not tolerated for rapid repletion is needed, then we need to give her IV iron with hematology and pediatric support. Because we have
Now my question is again to all the panelists, because her hemoglobin is 8 gram. So will you start with oral, or you will, I mean, in your practice, you will prefer to give her IV iron because it is very, very safe. So how many of you will go ahead with oral iron along with your OC pill, and how many of you will go ahead with IV iron?
I will go with oral iron.
I give her iron sucrose, the parenteral.
Shobha, will you go ahead with oral iron or IV iron? I think Shobha is busy, but yes, you can take a call if she is hemodynamically.
Sorry, Lakshmi.
Yeah,
Sorry. Yeah. Intravenous iron definitely can be considered as the next line if there is intolerance to oral iron. So a documented intolerance to oral iron, and we can give the intravenous therapy. There is absolutely no problem. But I think,
you
oral
all
iron
agree?
should be tried first.
Oral iron,
Yeah.
proper method, you have to tell her.
Yeah.
The proper method of absorption, you have to take parents into confidence, you have to put reminder into her mobile, you have to check for compliance of oral iron, you have to give her diet counseling. So, and if she is having any intolerance to it or there is a poor compliance, then you will consider the IV iron for it. Now coming to the
think a little bit extra input here, because I feel that correction of anemia clinically on ground can be one of the hardest things to accomplish, especially in young girls. So probably if we make it multidisciplinary, bringing in a pediatrician also, because 14 years today is considered as pediatric also dietitian. So probably we must focus on controlling the cycles, take help, because otherwise we may not succeed in correcting the dietary disorder and the anemia, etc. That was the message I wanted to give, Lakshmi. Yeah.
Yes, because here there is a role for the multidisciplinary approach for this girl. Now, this is the third aspect which you have to treat simultaneously. So now, Janani, you can pitch in.
Yes, ma'am. So we have various questionnaires that help, which we can do in our OPD, like you mentioned, in a very quick span of time. One of the most common questionnaires, a psychosocial assessment, which looks at the person's mental well-being on the whole, would be the HEADS, the SCOFS questionnaire, which looks at food restriction, the binges, the compensatory behavior, and like I mentioned, the body image and the social media influences. Now, if it is a positive screen that we get on the questionnaire, then there is a multidisciplinary treatment that is required, an assessment and a treatment that's required. So we know that the medical severity criteria for urgent admission is BMI, which is really low. If the person has bradycardia, if the person has orthostatic hypotension, severe electrolyte imbalance, and in case of psychotherapy for a very young person, we definitely look at family-based therapy, because a lot of these eating disorders are genetic, they're hereditary, and they also come from dysfunctional families. So it's very important to get the family into treatment and therapy so that the child improves on the whole.
Great. And this is, of course, for us clinicians, that we have to educate her and we have to treat her about her long-term menstrual control and fertility counseling. Now, follow-up slide is there. So I would like Suman to answer for the audience how you will call, when you will call her and what things you will monitor for this girl.
Yeah. So regarding follow-up and monitoring, we'll call her after 1 to 2 weeks and check for the adherence, if she is taking the medicine properly or not, if she is having issues with side effects. Then we can repeat hemoglobin if she is symptomatic. Otherwise, in 2 weeks, we are not going to repeat the hemoglobin percentage. But again, I will call her after 4 weeks, and I will like to do a CBC or peripheral smear to look for the reticulocyte. If it is rising, then we are happy. And also we'll look for the percentage of hemoglobin, if it is rising or not. If again, if we see that there is no rise in the hemoglobin percentage, even after 4 weeks, then again we'll have to check for the adherence, if there is issues with the malabsorption. And then as Suhagudi madam has already said, that we will go for the IV iron.
Or you will have to investigate further.
Yeah, and yeah. And one thing is very important, even if she is having a normal level of hemoglobin percentage, we have to continue giving her iron for additional 3 months.
Yeah, you have to build her iron stores as well. Here again, as a clinician, there is an importance for documentation. So you should document all the things. What Shobha was saying is the multidisciplinary thing. For this girl, you have to involve the dietitian. You have to involve the adolescent psychiatrist or psychologist. You have to involve the pediatrician. You have to involve the hematologist if you are suspecting bleeding disorders. And you have to involve the school counselor for her academic performance. So to summarize this case, you have to treat the girl from all the front, and you have to do basic investigations, treat her for HMB, treat her for iron deficiency anemia, try to correct her eating disorder. Don't assume that all teen HMB is anovulatory. They are not. Sometimes it can be because of bleeding disorders. Don't treat iron deficiency superficially, because poor adherence in this age group is very, very common. And don't ignore disordered eating, that I am a gynecologist. It is not my part to counsel her or to look into the disordered eating, because sometimes it can be life-threatening and it requires early multidisciplinary care. And we are the first point of contact for that adolescent girl. So it is our duty to take eating disorder also seriously. So you have to refer if SCOF is positive. So I will just tell you, this is the SCOF. This is the acronym. There are a very, very simple questionnaire. You can keep it with your nursing staff at your registration desk. It hardly takes 3 minutes for your staff or for your patient to fill. Each yes answers the 1 point, and if score is more than 2, it suggests a eating disorder and it warrants further evaluation. So why this questionnaire is important for gynecologists? Because many adolescent girls, they present with menstrual irregularities due to underlying eating disorders. And the SCOF is a very quick tool which you can apply in your clinic to pick up the hidden eating issues behind the gynecological symptoms. This is the E26, again, most widely used standardized self-reporting screening tool. You can keep this also at your reception desk. It also takes hardly 3 minutes for the patient or your staff to complete this score. It has 26 questions. Total score, if it is more than 20, she is at risk of eating disorder. Remember, this is not a diagnostic tool. It is a screening tool, and it is a quick, validated, and widely used to screen adolescents for eating disorder. Third thing which I have mentioned in my report, my slides, is family-based treatment. Friends, again, as a clinician, we cannot say that this is not in my domain. We have to be familiar with these two questionnaires, that is SCOF and E26, and we should be familiar. You should not treat her, but you should be familiar with this family-based treatment, that is Mosley approach. This is the evidence-based first-line treatment for adolescents with eating disorders, and it works on the principle that adolescents are best supported in recovery when families are actively important. It has 3 phases, that is weight restoration, returning control to adolescent, and establishing healthy identity. What is our gynecologist role in this approach? That many adolescents with eating disorders, they first present with menstrual disorders, amenorrhea, or infertility concerns to us. So we should be able to screen them. We should be able to identify the red flags, And once we identify the red flags, we should be able to refer them for multidisciplinary care. So this is our role, why we should be familiar with all these questionnaires and the approaches. Now we are having no time left, so I would just quickly ask all the panelists to give their take home for all these two cases which we discussed. First was on the recurrent UTI and second was on the iron deficiency anemia and HMB. Would you like to give any take home, because there is no time left for to discuss the third case?
Can I say
Quick,
that?
otherwise, yes.
All
Radhika.
cases of UTI cases cannot be only urinary tract infection. We have to look for STIs also, because it can be associated with UTI if patient gives, the adolescent girl gives history of sexual relations.
Radhika?
So, comprehensive, yes, ma'am. Comprehensive history taking, symptoms and everything should be included, and not promise confidentiality, but at the same time, in a sympathetic way, empathetic way, we need to take history. The partner note, treatment also should be given.
Shobha?
Hello, Lakshmi. Yeah, Lakshmi,
Yes.
I just wanted to thank you for the excellent case compilation. And I'm really happy to be part of your panel discussion. You have put in so much efforts and you have brought in so much information. So thank you so much for doing this. I really enjoyed, and I'll be boarding the flight now. I think
Okay,
we
thank
gave a
you.
lot of
Thank
good
you, dear.
messages. Thank you. Thank you.
Shobha, that
Janani,
is
would
the
you want
reason
to
we called Lakshmi Madam for moderation. That's
Correct.
I know
And
Sampath
Sampath,
called me.
always
thank
we'll
you
do it.
so much for calling me. Sampath,
Sampath said
first I
you should
thought I
not
won't be
discuss
able
the
to do
routine
it.
case scenarios. You have to come up with different case scenarios
Yes,
in your
yes.
panel. And I hope Sampath I did justice to your
Yeah,
expectations.
correct.
Yes, madam. Fantastic.
Yeah. Sampath, Dr. Sampath, thank
Huh?
you so much for including me in the panel. Thank you.
Definitely.
Janani, would you like to say anything?
First,
Janani,
I thought
because
I
we
can't do it. Thank you so much. Thank you.
Ma'am, I forgot I
Janani?
was listening to gynecologist. It felt like I was listening to psychiatrist or
would you like to give,
the
because
mental health system is
there are so many psychological issues with adolescent. Practically speaking, whenever they come to us, as I mentioned in both the cases, they are having so many psychological issues which are hidden. We as a clinician, we gynecologists, we really don't pay attention. I emphasize in my second case that sometimes the eating disorders can be responsible for her menstrual irregularities. Eating disorders can be responsible for her anemia, which we never bother. I mean, we clinicians, we just treat. Okay, hemoglobin is 8 gram, take iron. You are having heavy menstrual bleeding, just take OC pills. So it's not like that. And in first case, I was emphasizing that if she's coming to us with recurrent UTI, how there is a conflict between POXO and our adolescent friendly services, and how we gynecologists should negotiate a bit, I mean, I say midway, because patient comes first, but at the same time, we have to protect ourselves also, because it is mandatory to report if she's less than 18 years of age. Now coming to Sampath. Sampath, you have listened to both the cases. Now you can conclude.
Yes, madam. Whatever you have told of the fantastic moderation and panelist with a good interaction. That is the reason I sent Janani psychiatrist my life, because you should understand that she is not a gynecologist.
This panel would have been incomplete without her inputs.
Yes, she is a nice, fantastic madam.
Thank
All
you,
the
Sampath.
two cases.
Thank you.
If time permits, we would have discussed about menstrual cups also. But
Yes.
anyway, the third case we are not able to do. Now, thank you so much, Lakshmi madam and Radhika, Janani, Shobha, and Suman Sinha. We'll go
I
with the
really
post
enjoyed
name call or
Sampath.
waiting. Yes,
I
madam,
enjoyed.
definitely. Yeah, always you enjoy. Whatever topics are different topic, if you give, you will enjoy. That is Lakshmi madam. Okay.
I hope I have given some really practical take-home messages to the audience. I mean, I really hope so. Yeah.
Take-home messages is always listen to the adolescent. You don't
Yes.
talk much. Always make the
Yes.
adolescent to talk and listen to them. That is the take-home
Yes.
message, madam.
Give them privacy, assure them that their information will be confidential. Of course, if she's less than 18, I mean, limited confidentiality. But once we give them these two assurance, they really open up.
Definitely.
And don't be judgmental.
Okay.
Don't preach.
Yes.
They don't like preaching.
Yes, always give them information. Don't give advice.
Yes.
Information is more
Information, so they have
important.
tons of information, Sampath. They are so much on Google and
That is
internet.
from the Google. That is from the Google, madam. Our
Counsel
practical
them.
information.
Counseling part is very important. We have to counsel.
We have to give them scientific information. That is what they look to us as a clinician, as a gynecologist, that you tell them what is right on the Google, what they have read is right, what is wrong. Give them scientific information and they will be really happy.
Yes, as of now, we have 198 participants with the faculties. All of you do the school counseling starting from nutrition to HPV vaccination.
Yes.
Monthly one, just 30 minutes. So now we will go to the post test. All are asking for post test link. Nilima, please post the post test link.
Yes, ma'am.
Thank you,
And
ma'am.
don't forget to counsel them for HPV. Whenever any adolescent comes to you for any reason, please catch that opportunity and counsel them for HPV vaccination.
We are giving.
Yes, Radhika.
Yes, ma'am. Could you? So all the delegates, please scan the QR code.
Link is already posted, Dr. Sudha. ராதிகா எல்லாரும் முடிச்சிட்டாங்களா?
So are we done now? Nilima?
Ma'am, 6 minutes left.
6 more minutes left, Radhika.
Sharing. Neelima?
Yes, finished. Yes. Hope everyone have answered. Really fantastic program. First, I thank our Foxy President, Dr. Sunita, and Dr. Swarna, Secretary, and our ICOG Chairperson, Dr. Parag, and Dr. Sarita, Secretary, for giving us an opportunity to conduct this ICOG certificate course. Repeatedly, I am telling this is the 8th time we are conducting consecutively the ICOG certificate course. Thanks to the faculties and the delegates. We had more than 450 registration. And I requested Dr. Parag, sir. He is there, I think. Dr. Parag?
I'm here, Sampath, I'm here. I'm in the car, so I cannot be seen. But on behalf of ICOG, let me thank the conveners, Dr. Sampath Kumari, who has done this activity for last 8 consecutive years. Thank you, Sampath, being the star convener of this program. And of course, thank you to our governing council member, Dr. Durga Shankar Das, and Dr. Supriya Jaiswal, the chairperson of Adolescent Health Committee, and of course, all 3 coordinators. Thank you, Radhika Gauri, for being so patient and sitting in one place for 3.5 hours. It's not easy, I understand. Thank you, Supriya Arwari, and thank you, Poonam Lal, for coordinating the program. I would also like to announce that the next program, the next certificate course of ICOG will be on urogynecology, which will be on the 17th, 18th, and 19th of September. Mind well, this is the third week, 17th, 18th, and 19th, and we would be happy to have many of you attending the next certificate course. Thank you very much, and please share the answers so that people will know. And just excuse me, I need to log out since I'm on the road.
Thank you, Parag. Thank you.
Thank you, Sampath.
Thank you. Radhika, can you read the answers first?
Yes, ma'am, sure. So the first question, what are the most important components of school counseling except nutrition, sexual health, mental health, physical education? So physical education does not come under the most important component. So the second question, menstrual hygiene day falls on December 28th, July 28th, March 28th, May 28th. So it falls on May 28th. That is the answer. Adolescents should have their meal with a mix of rice, pulses, oil, protein, rice, pulses, fruits, vegetables, rice, pulses, fiber, vitamins, minerals, and oil. That is the answer. 3.
You read only the answer, Radhika.
Okay, ma'am. What is normal menses? Number 1 is the answer, 21 to 35 days once. So 5th question, anemia in adolescence is defined as HB less than 12 grams. The next question, in an adolescent girl newly diagnosed with acute lymphoblastic leukemia, induction chemotherapy must be given within 48 hours. So what is the most evidence-based feasible option for fertility preservation in this scenario? C, ovarian tissue cryopreservation by laparoscopic cortical strip harvesting. Which of the following cancer types in adolescent girls presents the greatest theoretical risk of ovarian tissue reseeding after autotransplantation? B, acute lymphoblastic leukemia. 8th question, in prepubertal girls with malignancy, which of the following is currently the only established and clinically applicable fertility preservation strategy? B, ovarian tissue cryopreservation. So 9, which of the following conditioning regimens prior to hematopoietic stem cell transplantation in adolescent girls is associated with highest risk of premature ovarian insufficiency? It is busulfan plus cyclophosphamide. 10th question, an adolescent girl with Hodgkin's lymphoma undergoes ovarian tissue cryopreservation. She later survives cancer, seeks fertility. According to current evidence, what is the most successful fertility outcome associated with auto-transplantation of ovarian tissue? C, both restoration of ovarian endocrine function and natural pregnancies reported. So 11th question, HPV is causally related with what percent of cancers worldwide? 5%. And 12th question, L2 protein of HPV assembling into VLPs forms the basis of HPV vaccine. True or false? It's false. Which is the most carcinogenic HPV type? A16, HPV 16. Those vaccinated with Cervarix have cross protection from other HPV types also. True or false? True. 15th question, vaccinating our boys and men does not contribute to herd immunity against HPV. True or false? False. 16th question, which statement about recurrence after adolescent endometriosis surgery is true? Recurrence is rare after initial surgery. Recurrence risk increases with longer follow, long-term surveillance. So recurrence risk increases with longer follow is the answer. At laparoscopy in adolescents, the most typical lesion morphology you should actively look for is clear or red vesicular flame-like lesions. A 14-year-old with hematocorpus from obstructed hemivagina and suspected secondary endometriosis, the key surgical priority is correction of the outlet obstruction, septum resection. Which of the following is a key principle in surgical management of adolescent endometriosis? B. Conservative surgery with minimal tissue damage. 20th question. Energy choice for superficial peritoneal disease in adolescents should prioritize any modality. Key is complete treatment with minimal thermal spread. That is the answer. Thank you. Thank you, ma'am.
Thank you, Radhika.
Thank you so
Thank
much.
you, Radhika. So those who have attended on all 3 days and answers 50% pass will definitely receive the certificate. One question 24 to 35 days, somebody has mentioned the normal cycle. It can be 21 to 35 also. I think this is the question set by the speaker. Thank you once again to all whoever has joined, the delegates. Radhika, again, thank you. Neelima, thank you so much for taking effort to get the questions from the speaker. Thank you.
Thank you, ma'am. Thank you, Sampat, ma'am. Thank you, Neelima. Thank you, ma'am, for the opportunity.